Welcome to Mastering Differential Diagnosis with the DSM-5, a symptom-based approach. I will be your presenter today. I'm Dr. Margaret Bloom. I go by Peggy. I'm Professor Emeritus of Counselor Education and Counseling Psychology at Marquette University in Milwaukee, Wisconsin. I'm a licensed psychologist and a national certified counselor. And at the present, I am an independent consultant and presenter. But what's most important today is my long-term experience and expertise that I've developed in diagnosis and treatment of mental disorders. And I've been teaching students, publishing articles, and presenting continuing education programs on diagnosis with the DSM since the DSM-3R. I know that makes me old, but it also makes me pretty familiar with the ins and outs of the DSM. Now, so that's who I am, but I would like to know who is attending today. So I am going to put up, and I would like you to let me know, what is your profession? Okay, so I'm going to close the poll in just 10 seconds. So if you haven't, I've got a few of you haven't answered yet. So if you'll answer, please. Okay, so I have a range of disciplines as I usually do. All of us use the DSM now, 5TR, and a lot. And I see social workers are the greatest in attendance today. Then we have counselors and psychologists, a nurse or nurse practitioner, and one drug abuse counselor. Okay, so let's get going. But first, I want to talk about some housekeeping, so you understand what we're doing. You're going to need available to you either the DSM-5, but preferably the DSM-5TR manual. Now, the manual is the big book. Now, because we're going to handle it, open it, read it, because that's the only way I know to really get familiar whenever there's a change. If, however, you don't have the manual and you have the desk reference, that works for some of it when we're looking at diagnostic criteria. And for those of you who haven't got it yet, can't go get it right now, I have given page numbers. So after the workshop, you can look. This is going to be 6 hours long. And I can tell you right now that how you get the most out of this is you do the polls, and then we do diagnostic written activities. And that's essential because that's how you learn. You learn by doing. We'll take a morning and afternoon break of about 15 minutes. And I have put here when lunch is on my time, which is Central Daylight Time. That's so that I don't get confused. But so adjust the time based on whatever time zone you're in. And I want to remind you that a handout of the slides and the materials are in the seminar manual that's should be along your screen, and so download it. Now, you've already discovered, since I see so many chats, that you use the chat to communicate with each other or to contact the technician who is helping us today. His name is Tim. And if you have a question for me, you put it into the Q&A. And I'll monitor that during the break. And so after the break and after lunch, I will answer at least a few of the questions. Often they're somewhat similar, so I can get them covered. And we'll have a time for Q&A at the end as well. I need to provide some disclaimers. The American Psychiatric Association publishes and holds the copyright for the DSM-5 TR manual and associated publications. I do not represent the American Psychiatric Association. All materials that are used in this presentation are either open source or used with permission. I am a partner in Psychopharm Legal Consultants in Milwaukee, Wisconsin. It's sort of my part-time retirement activity, along with my husband, who's the other co-partner. I have no financial interests in any mental health treatment or pharmaceutical organization. PESI is paying me an honorarium for this presentation. Now, what are we going to do today? Well, you saw when you signed up, there was a list of learning objectives. And so it said what you would be able to do after you took this. But I have in my mind what I call goals. That I have for you. And I really want to have you enhance your diagnosis skills to more effectively and accurately identify DSM-5 TR mental disorders. Now, this is an intermediate to advanced seminar. I'm assuming that you are familiar with the DSM-5, and I'll be helping you catch up with the DSM-5 TR. Not huge amounts of changes. I designed this seminar then to build on existing basics. And so my goals for you are that you learn the essential changes in the DSM-5 TR. You learn how to make a differential diagnosis, taking a symptom-based approach, which is what really works well with the DSM-5, and to learn how to practice. Practice is how you develop expertise. So I want you to practice with somewhat more complex cases than you probably were exposed to either in your psychopathology class or a seminar on using the DSM-5. So as most clients are more complex than those simple examples, that's what we'll be using today. So let's talk about diagnosis of mental disorders. And mental disorders are among the most difficult to diagnose of human disorders and conditions. And, diagnosis of mental disorders is much less clear than diagnosing, say, a urinary tract infection or heart disease, because many of medical conditions have a signal symptom. So if the physician or the nurse practitioner discovers the presence of that symptom, like streptococcal bacteria or a tumor, they pretty much know where the diagnosis is going, maybe with a few more tests. But that's not the case with mental disorders. There is no signal symptom. So we have to make our diagnosis just based on a pattern of thinking, feeling, and behavior that we've gone to recognize as a particular mental disorder. It's a categorical approach. If you have this pattern, then we're going to say you have this mental disorder. Compounding that is that mental disorders occur on a continuum. So, and there's no clear boundary between, well, that's just normal. Oh, that's just a little odd. Or this is a mental disorder. And so it's arbitrary where we draw the boundaries. And essentially in the DSM-5 the boundaries are established by the diagnostic criteria. They say where that you move from odd to a mental disorder. But as a result of this sort of, what shall we say, arbitrariness or ambiguity, there is no definitive identification of the diagnostic system for mental disorders. There's just models or different kinds of systems. And there are a number of diagnostic systems available. The most universal is the ICD, the International Classification of Diseases, which is supported by the World Health Organization. And we're now in version 10. Now, since 1952, clinicians in the United States use two diagnostic systems concurrently to diagnose a mental disorder. This was established, as I said, in 1952 by the federal government and Department of Health and Human Services. We use the DSM, the Diagnostic and Statistical Manual of Mental Disorders, published by the American Psychiatric Association, and we're now in version 5TR. And we use those to correctly identify the disorder. And then we use the ICD-10 to properly code and report the disorder. And just to add, we now have the ICD-11 was released, and I'll talk more about that in a few minutes. So let's review quickly how we use them together. As I said, the DSM-5TR helps us, gives us criteria for a specific mental disorder and gives us the proper name that is proper in the United States. And the ICD-10 CM, the CM stands for clinical modifications. Every country in the world has to use the code numbers as given, but they have the permission to make what clinical modifications, that is, use a different name or define their own criteria, which is what the DSM-5 does. So in the United States, we use the ICD-10 clinical modification. And that's going to list the codes and provide several sentences about any disorder. And the International Classification of Diseases classifies everything that could possibly cause human mortality and morbidity. And that includes diseases, accidents, acts of violence. It covers it all. The mental disorders are only one chapter in the ICD, and that's chapter 5. Now, let's look at this example. It's an F43.10. That's the ICD code. And the name and the criteria we use comes from the DSM-5-TR, post-traumatic stress disorder. And then I've added the required specifier, it's severe. Now, I do want to say before we go on, you do not need to purchase the ICD-10 CM because the DSM-5-TR gives you the choices to make among the codes when you make your diagnosis. So everything you need is going to be in the DSM-5-TR in respect to the ICD. So I want to talk just a little bit more. And you notice that I said I want you to have the manual for today. And what has happened over time, the original DSM-1, and a long time ago, a retired psychiatrist brought his DSM-1 to one of my workshops, and it was just a little pamphlet giving codes and names. And over the years, it has really grown. And so we now have 298 mental disorders. And it gives the criteria for all of those. And essentially, it's in the manual, and it's also the criteria are in the smaller desk reference of the DSM-5-TR. But also what has happened, you can see how wide this is that it has become a reference resource about every disorder. And most of the changes in the DSM-5-TR is to update and give the last 10 years of clinical research in what we've learned. So for each disorder, I just opened it to anorexia nervosa, and after the diagnostic criteria, the text material starts. And every disorder has sections, the diagnostic features, the prevalence, the development course, the risk and prognosis, the culture-related diagnostic issues, which has been enhanced, sex and gender-related diagnostic issues. So it'll tell you about how it varies by gender or by ethnic group. And new to the 5-TR, there's now a section for each disorder on the association with suicidal thoughts or behavior. Then it talks about functional consequences. And then these last two, there is a differential diagnosis section, and we're going to use that a lot today. And there's also a section about comorbidity with each mental disorder, and we'll also be using that quite a bit today. These are really valuable resources, and you need access. If you don't have to own it, but if you work in an agency, there has to be at least a couple copies available for your use. Now, remember the title says a symptom-based approach. And that's because to become proficient at making a diagnosis, you have to understand how the DSM diagnostic system works. And that is, if you see on the slide, that mental disorders are syndromes, this is right out of the DSM, patterns of disturbance in an individual's cognition, emotion regulation, and or behavior that reflect a dysfunction. That is, it impairs the person's functioning. So here's the visual I have here. So if you think about it as symptoms that the client is experiencing are the building blocks of a syndrome that can be recognized. That is a pattern. And so here I've got hard to concentrate, tearful, irritable, sad, weight loss. Well, and you probably quickly recognize that that's a syndrome of depression. That when we see this pattern, we say, oh, I wonder if this is depression. So I already mentioned how hard it is, but what makes it even more difficult is every client presents with an overlapping set of signs and symptoms about what's troubling and what's interfering with their daily functioning. So these overlapping symptoms, and notice I have here crying, or tearful, anger, difficulty concentrating, tension and anxiety, are seen in multiple patterns. They're symptoms that are part of a pattern, and that could be the pattern of anxiety, the pattern of depression, and so on. So how we recognize a mental disorder and start going towards diagnosis is we have to recognize the syndromes that the client has, the patterns. And I'm using plural because rarely is there just one syndrome that the client presents. This will come clear as we go along. So, how do we identify a mental disorder? Now, I know many of you know this already, but what I found in doing these over the years is it's important that I make sure that we all have kind of a refresher on the DSM and that we're all starting from the same level of understanding. Partly, too, because most of us learned it not in school very well, but on the job. So how do we identify a DSM-5 mental disorder? Well, we use the diagnostic criteria set for the potential diagnosis. Okay, so here I'm going to open it up again, and I opened it up to schizophrenia. And then there is criteria for that, and I check to see. And what I have to make sure is that the client's symptoms and frequency of symptoms and so on matches, and everyone is met, like, because the letter criteria. So, for example, here, I'm in brief psychotic disorder, criteria A, presence of one or more of the following symptoms, and at least one must be delusions, hallucinations, and disorganized speech, and then there's disorganized behavior. Then there's B, duration of an episode of the disturbance is at least 1 day. So every letter of the alphabet in the criteria has to be met. And then if the symptoms, the severity meet that diagnostic criteria, then I'm going to assign the specific disorder name, and then I'm going to specify the severity and other specifiers. And I'll say it one more time, and that is that with the DSM-5, it became required that every disorder has a severity specifier. And then you will be offered other ones as well, that you can apply if they fit. Now, we've talked a little bit about the DSM-5. Let me just do something quick with that other part of our diagnosis system, which is the World Health Organization's International Classification of Diseases. And this is a global standard. The DSM is used mainly in United States, Canada, and Australia, English-speaking countries. But the rest of the world may have other manuals they use, but everyone uses the ICD that belongs to the World Health Organization, and almost every country does. They use the ICD coding system. And I've already talked about what it is. I've talked about clinical modifications, and the ICD Chapter 5 is for mental disorders, and it contains the codes. Most of the codes for mental disorders begin with the letter F. F is the alphanumeric beginning of the codes for mental disorders. Now, I mentioned the ICD-11 on the previous slide, and it has already been developed. The United States was the very last country in the world to adopt the 10. And it had been released in the early 1990s, but because of our healthcare system being so splintered, and because we have this weird idea of using a diagnosis to get reimbursement, and so the code gets real important, it was a big undertaking to switch to the ICD-10, which was alphanumeric rather than just numeric. So now we've just barely gotten used to that. We've been using it now for 7 years, and the 11 was released this January, and it includes not just codes, but it does include clinical descriptions and diagnosis requirements. And so it's moving the DSM and the ICD are, in terms of mental disorders, are starting to look more similar in terms of content. The prediction is that it'll be quite a few years more before the United States moves to the 11. I do think it is very important for you to feel confident in us picking which ICD code is appropriate, because many disorders now have multiple codes that you choose from, that you understand how the ICD coding system works. So we have, here you can see we have 3 digits before a decimal point, and then we have up to 4 digits after the decimal point. And so the first digit is always a letter of the alphabet. And as I've already said, most of our codes for mental disorders begin with F. Then the next 2 digits are numbers, and they give the kind of category of the name of what the disorder is. So here we have an F below in the example. Okay, we have an F, and then in the next 2 digits, we have a 90. So, and that is the number for attention deficit hyperactivity disorder. Then we have the decimal point, and the digits after that are used to tell us more about exactly what kind of ADHD does this client have. In other words, the whole trend, this reflects the whole trend in treatment and care for mental disorders, which is that we try to match our approaches to the specific form. Say depression, it appears in a variety of forms. Some clients have a lot more vegetative symptoms. Some clients maybe are almost delusional. So I won't treat them the same. I need to tailor the treatment. And so they also want to get more specific in reporting. And so here we're going to find, and then often for us, this digit, even though it says severity over here, this is, it tends to be here. And so in this case, we have an F90, which is attention deficit hyperactivity disorder. Then we have a 0.2, and I pick that because 0.2 designates that it's the combined presentation. That means the individual has symptoms of both inattention and hyperactivity. And then I write out the name moderate. Now, in a lot of the disorders, there'll be a number to indicate severity, but not in all of them. So I end up then with the diagnosis. And if you don't remember anything else that I talk about today, I want you to remember that in the DSM system now, since the 5, diagnosis, a person's DSM diagnosis is a list. It's a list of every diagnosis the individual has. And if you look here and if you remember the axial system, you'll see what the list is it covers the same material, but doesn't say, there's this one disorder, and then that's the only diagnosis. And this is just bringing us, the mental health disciplines, up to use the diagnosis in the same way that our internist does. And so when I look at my printout from my doctor and I look at diagnoses, my diagnosis list is about this long. Hey, I'm a senior citizen, so I have a few chronic diseases. So we do this the same way now because it conveys more accurately, describes our client and what it is that we're dealing with. So in this case, the client has an F32.2 major depressive disorder, single episode, severe, with anxious distress. Notice the specifiers. Then the individual also has the diagnosis of F45.22, body dysmorphic disorder, that's F45, and 2 indicates that the severity is moderate, and the person has body dysmorphia. Body dysmorphia is it should be which is just a form of concern about your body's not developed enough. It's more of a male diagnosis. Then we have diabetes as diagnosed by the pediatrician. Remember, we used to have, we would put and this is here, you're going to list as part of your diagnosis any medical condition that might have an effect on the individual's mental symptoms and so on. But unless you're a nurse practitioner or a physician assistant or a physician, we don't diagnose medical conditions. So notice I have here as diagnosed by the pediatrician. Or I could, if I don't get a referral or anything, I would put as reported by client. Okay, and then I also have a Z code. Now the Z code is the alpha number assigned to other conditions that may be a focus of clinical attention. And in this case, it's underachievement in school. So notice how by having this complete coded diagnosis, I can start to think about this client and kind of, it's probably a kid. They have body dysmorphic disorder, and they're not doing well in school, as well as having diabetes, and now they're depressed and they're anxious. Now, ever since the 5 and continuing with the 5TR, the American Psychiatric Association has a website that provides additional DSM information. And these are free. You don't even have to own yourself a manual or to use them. So here's the web address. It's DSM.org. dsm.psychiatryonline.org. So let's pretend I click this, and this is the landing page. And it'll say DSM library. And so let's look at what's on this page that's real. Okay, so we see that here on the left hand, below the table of contents, there is a link to online assessment tools. These are free assessment tools, and I'll talk about them in just a second. Then on this side, notice it says additional resources, and I'm pointing towards the DSM-5 TR fact sheets. And this would be really important if you want to read about any specific change. So, what kind of free online tools are provided? And by the way, this has been really upgraded for the 5TR. And so I want to explain, there's different categories. So what we're going to focus on the most is level 1 and level 2, but there also are some severity measures. They provide a disability measure, which you use instead of it, which it's recommended you use. And then there's some instruments on early development and home background. So a particular use, I want to talk about the cross-cutting symptom measures. And these are in the level 2. So I've clicked on that section and notice that I have cross-cutting symptom measures for adults, for parent guardian reporting of a child, and for at a child ages 11 to 17 who can take it themselves. 2 of these are also printed in the DSM manual, but you'd want to get them here because they are ready to be downloaded, printed form, and ready to use. And then this is a screening tool. Think of it as a symptom checklist, but that is much more refined. You would give this to every client as a screening tool. It can also be used then as a follow-up at the end to show improvement. Then to be sure you really have identified or know more about what the client may actually have, we have cross-cutting measures too. There are ones for children, but I'm just showing this. So just the other day, I was looking at level 2 anxiety for the adults. And what it does is it helps you narrow down. Once you know what category, then it helps you confirm that you're in the right category of disorder. So let's take a look at a specific instrument. And this is the DSM level 1 cross-cutting symptom measure. Now, what does cross-cutting mean? It means that there are symptoms that overlap, but can be teased apart by knowing specific things. So notice that here we have 13 symptom domains, and see how they're alternate in color. And so let's look at the domain feeling nervous, anxious, feeling panic or frightened, avoiding situations. And then I say how frequently it happens, and how much it's bothering me. And then I rate it. That's the advantage over a behavior checklist, because what we're doing here is we're getting an indication of how severe that particular symptom is currently. Then there is a way to average the score for that domain. And if you want to, then accompanying it, and it's in the DSM-TR on page 844, is the threshold. So it'll tell you, yes, it's some anxiety, but it's not the level of an anxiety disorder, or it'll confirm that it is. And it covers all the major, this instrument covers all the major categories in the DSM. Okay. Now, if you have questions, just put them in the Q&A. One thing that I find hard about doing this as a webinar and not seeing your faces or whatever is I can't tell what's clear and what isn't. But, we have to keep moving on. So we've now talked about how, we've refreshed you on how we make diagnoses in the United States. Now let's talk about what's new in the DSM-5 TR. And these are the components of the DSM-5 that have been revised in the TR. There is additional narrative text. I've already mentioned that. There have been changes in the assigned ICD-10 codes. There are new mental disorders and other conditions, though fewer than in previous revisions. There's changes in mental disorder names. There's revised criteria sets. There's additions and revisions to the specifiers for a diagnosis. And then section 3 on culture has been greatly expanded. So let's dive into this a little deeper. And I put this here to remind myself to tell you that among the handouts, I have created a kind of a quick sheet of all the changes with the page numbers in the manual where you would find that addition or revision. Okay, so new mental disorder. Now, there are a lot of minor changes, mostly to improve clarity or to fill in a gap. So what I'm going to do, though, is just pick out the changes that you need to know about. And I'm doing it from the perspective of someone who works with children, adolescents, or adults with a variety of diagnoses, not a specialty area. So the one new mental disorder that you need to think about be aware of is F43.8, prolonged grief disorder. And if you have your manual, I'm going to encourage you to go to page 322 right now. The first thing you should notice is that it is in the category of stressor, of trauma and stressor-related disorders. So it's considered a stress-related disorder. And you'll notice on page 322, at the bottom is where we have the diagnostic criteria, and that the stressor in this case for it being called this type of disorder is the death of a person who was close to the individual at least 12 months ago. So it's a death, but it's a death that happened at least 12 months ago, or in children and adolescents at least 6 months ago. And remember, I talked about syndrome. The key syndrome, excuse me, the key syndrome is a persistent grief response. And we have here in the diagnostic criteria, after A was the stressor, B, since the death, the development of a persistent grief response characterized by one or both of the following symptoms. And then that is the intense yearning or longing for the deceased. And it often is accompanied by intense sorrow and pain, emotional pain, and preoccupation with the thoughts or memories of the deceased. And then for children and adolescents, this could be a preoccupation with the circumstances of the death. And so we've got that. Then, since the death, we're now at category at criteria C. Since the death, at least 3 of the following symptoms have been present most days to a clinically significant degree, and they have occurred nearly every day for at least the last month. And these are identity disruption since the death, marked sense of disbelief about the death, avoidance of reminders that the person is dead, intense emotional pain, which is often anger and bitterness as well as sorrow, difficulty reintegrating into one's relationships and activities after the death, emotional numbness as a result of the death, feeling that life is meaningless as a result of the death, and intense loneliness. So you have to have at least 3 of those 8 symptoms, as well as having the key syndrome, which I have listed here on the slide. And then the disturbance causes clinically significant distress or impairment, the duration and severity of bereavement clearly exceed expected social, cultural, and religious norms for the individual's culture and context. And then what I always call the exclusion criteria, the symptoms are not better explained by another mental disorder, such as major depressive disorder or post-traumatic stress disorder. So one of the major differentials I've mentioned 2, I have more. So here on the left, I have the criteria for the prolonged grief disorder. we just read it, and I've just highlighted A, B, C, and F. Okay, so how do I differentiate it? Well, one you have to think about is major depressive disorder, because it can be preceded by the death of a loved one. But if you look, the person meets the criteria for major depressive disorder and not for prolonged grief disorder, or it could be comorbid, but in that case, the person has to independently meet the criteria for each. Another one, especially if the death was due to trauma, is post-traumatic stress disorder. And usually in this case, the death was due to violence or an accident, and the person has intrusions about the traumatic event of the death, versus the focus in prolonged grief disorder is on the relationship and memories of the loved one. If it's PTSD, there's avoidance of thoughts and feelings associated with the traumatic event, versus always thinking about reminders of the loved one who is dead. And then in PTSD, we have re-experiencing of the traumatic death as if it's here and now. Okay, another possibility, of course, is that it's an adjustment disorder, because, they talk about that it's a reaction that's out of proportion to what could be expected. But in this case, because of the time limit, adjustment disorder lasts less than 12 months after the death of a loved one. And then finally, there is a uncomplicated bereavement and another existing mental disorder. That is, the person has lost someone, they're having normal bereavement, but there is another mental disorder. So the person is, in fact, having dysfunctional impairment of daily functioning, but it's due to that other mental disorder. Okay, so that's the one new mental disorder. Now, in the 5TR, there are two new other conditions that may be the focus of clinical attention that are really important and you need to think about. And that is, one is suicidal behavior, and the other is non-suicidal self-injury. These will help you document either, that the client, that part of their diagnosis list, they are suicidal, or they engage in self-injury, and that it's going to be part of your treatment plan. I also want to note that you don't have to have a mental disorder in order to list either of these conditions. We can make a DSM-5TR diagnosis, and on that list, we could have just suicidal behavior as the diagnosis. They have Z codes, and you choose among the Z code of what fits. So what is suicidal behavior? The key idea is the individual has made a suicide attempt, or been expressing and by engaging in this behavior, at least some intent to die as a result of the act. If they're just thinking about suicide, or they change their mind before initiating an action, then you would not use this diagnosis. So it's actually have to have been behavior, that is, they've made an attempt. The other, and you pick it out at history of suicidal behavior. They're not currently engaging in it, but they have a history of it. And then say you met them in the, you work in the ER, and suicidal behavior, initial encounter, starting to sound like what you get on when you go see your medical doctor. First encounter, follow-up. And then there's a code for subsequent. Now, what is it? That doesn't mean the next time you see them. What that means is on the initial encounter, then you've got a period of therapy. They're gone. Then let's say this has happened before. They have a history, and now they're engaged in it again, and they have to come back for more counseling or therapy. Then the other condition, non-suicidal self-injury. That's also a behavior, and that is when the individual intentionally inflicts damage. So it's self-inflicted damage to the surface of their body of the source of the type that's going to induce bleeding or bruising or pain. But the expectation in doing it is that it will lead only to mild or moderate harm. So it's behavior like cutting or, burning with a lit cigarette. It's self-injury, but it's without the intent of doing serious harm. And here there is a time frequency requirement that they've done it at least 5 or more times in the past year. So I think these are really valuable additions. And if you want to know more about them, oddly enough, there is in the DSM-5 TR, there's a section called Conditions for Further Study. And there they've proposed diagnostic criteria for each of these. And if you read that, it'll help you better understand what exactly the client is doing in the behavior that would lead to this diagnosis. Now, there have been a number of changes in the name of a disorder. And the ones that I think you might encounter are that conversion disorder has been renamed functional neurological symptom disorder. And what it does, that is where the individual has an altered voluntary motor or sensory function. So it's one or more symptoms of either your voluntary motor function or your sensory functions have occurred, but it's incompatible with known neurological or medical conditions, such as loss of hearing with no damage to the nerves or the blood circulation or ear structures. So, and there is a coding note that helps you pick which ICD-10 code to use. There are 8 different codes that indicate what is the type of function that has been lost. Conversion disorder, that name came from psychodynamic Freudian type medical terms, and slowly all of those terms are eliminated from the DSM-5 and 5-TR. Okay, the other is that, as anticipated, intellectual disability, which was the new term for mental retardation that was introduced in the DSM-5, has been renamed intellectual developmental disorder. And it fits then with what the name of it is in the ICD-10. It is, and it also clearly indicates that it's a neurodevelopmental disorder. And so it's a disorder of both intellectual and adaptive functioning deficits with a failure to meet developmental and sociocultural standards for personal independence and social responsibility. And in this case, there are 4 ICD-10 codes to pick from. And it's and what the difference is, you're indicating the level of severity from mild to profound. Now, the others, I've already commented about Freudian psychodynamic names, that in the DSM-5, they had renamed dysthymia to be persistent depressive disorder and then put dysthymia in parentheses. It's gone. You will not find that word again. And the same for social phobia. It was changed to social anxiety, but they kept in parentheses social phobia, and it's now been eliminated. You should not use those terms. The other term that the 5 eliminated was hypochondriasis. So we are getting to the point now which is what the DSM-5 and 5-TR are about, which is we're now talking about observable signs and symptoms with an emphasis on including the biological. Probably the one if you read the press release that the American Psychiatric Association put out about the DSM-5-TR, they say that there were modifications to the criteria sets for more than 70 disorders. Well, that's true, but many of them are minor or rarely encountered disorders. So what I did is I went through all of them, and I've identified 4 that counselors would probably encounter, and and psychologists. So what I'm going to suggest you do is that we go to each one of the criteria sets for these. So if you'll get your manual, let's go to autism spectrum disorder, and look at criteria A, and that's on page 56 of the manual. Okay, and in criteria A, what they've done is they've made it clearer that all 3 types of deficits are required to diagnose, to say this is autism. And it was misleading in the 5, and many people thought that that, you could have it with just, deficits in one, but you must have deficits in social emotional reciprocity, in nonverbal communicative behaviors used for social interaction, and deficits in developing and maintain and understanding relationships. By the way, one thing I do like about the 5TR is the color, they have a highlighted like different color. It's not just white, so that you immediately see where the diagnostic criteria are as you're thumbing through. Now, I mark all of mine with tabs, but it gets to kind of crazy. You get so many tabs that I still end up fumbling around sometimes. Okay, the second one that we want to look at is substance medication. And we really don't need to go look at this one. Substance medication-induced bipolar and related disorders. They've again clarified criterion B1 that says that you can't diagnose a substance or medication-induced bipolar or related disorder. It has to be after exposure to or withdrawal from the medication. Pretty simple. I think that's something we all understood, but they wanted to make it very clear. Some more changes. In major depressive disorder, criterion D has been revised in the 5TR to read: at least one major depressive episode is not better explained by a mental disorder on the schizophrenia spectrum or other psychotic disorders. And what they're trying to do is make sure that you have thought about, is this schizoaffective? Or is this a major depressive disorder? And rather than say the current episode has to be that way, it's just saying at least one of the person's episodes is not better explained by schizophrenia, because a person can have schizophrenia and also have a major depressive disorder episode. And so, in other words, I'm going to say it one more time. Clients may now be diagnosed with major depressive disorder, whether or not the current episode of depression includes symptoms of psychosis, as long as over their lifetime they have had at least one major depressive disorder without concurrent symptoms of another mental disorder. Got fuzzy? It has, when we talk about psychosis this afternoon, we'll go back to that. Then in avoidant restrictive food intake disorder, there in the DSM-5, there was a requirement that in criteria A, that the eating and feeding disturbance was manifest by a persistent failure to meet appropriate nutritional or energy needs. Further research has suggested that was too restrictive because there are different patterns of avoidant restrictive food intake disorder. And so now criterion A states that it has to be associated with one or more of the following symptoms: significant weight loss, being dependent on internal feeding or oral supplements, significant nutritional deficiency, or marked interference with psychosocial functioning. It doesn't have to include failure to meet appropriate nutritional needs. There's been changes in specifiers for specific mental disorders. Now, beginning with the 5, there's been much greater emphasis on specifiers, and it's the direction of the ICD coding. You know, like we've talked, they have numbers now that you pick to which number to apply to the client based on the specifiers. So it was new to the 5 to have all that. So they've now done some adjustments. If you want to think about one of the major reasons for the 5TR, it was to better improve the fit between the ICD-10 aiming towards the 11 than the DSM-5 was. So persistent depressive disorder, there are now only 2 specifiers: with anxious distress and with atypical features. In bipolar 1 and bipolar 2, they added a specific specifier that the person is currently in a manic episode. That was a mistake. It was left off. When they switched, I don't know if you remember, but in the 5, they broke up what had been called mood disorders. And so that there's 2 separate distinct categories. There's bipolar, and then there's depressive disorders. This was based on research that shows that bipolar disorders have as much in common with schizophrenia because of shared polygenes as they do to an affective regulation disorder. So, but in that switch, they forgot this specifier with a manic episode. So it's been added. And then under in the other specified obsessive compulsive disorders, which is on page 294, they added a new specifier that kind of matches up with something that's in the ICD-10, and that's called olfactory reference disorder. And that is when the person, has a particular focus on smelling. They smell a bad smell and they obsess about it. And because that doesn't really fit the criteria for a regular obsessive compulsive disorder, it's an other specified. And just help you recall, we use other specified in the DSM-5 and 5TR when we're very sure the person has a disorder that's in that category, but the person does not meet the criteria set for any one of the specific disorders in that category. Okay, codes. The codes that are applied to specific DSM-5 and 5TR disorders have been evolving. And every year, the National Center for Health Statistics issues adjustments. Remember, we're using two diagnostic systems at the same time, and it's not a perfect fit. In fact, I'd say it's about a 90% fit. So that 10% is the one that has caused having to rethink things. So every year since 2015, the APA has released something called the DSM-5 updates, and you would get them off of that webpage I showed you. In fact, they're still there. And believe it or not, there's already been a code change since the DSM-5 TR was released. So what they've done then is, rather than have this, they've taken all those updates and they've changed and given you the right code number for many disorders. And so you don't have to worry about that. I mean, it's right there, it's given to you. However, you do need to remember that there are yearly updates posted, and they're only posted on this website, www.psychiatry.org. And here are the first changes. And so what I have done each year is I download the update, and then I go to my manual and I pencil in the change code or sometimes the changed criteria. And so already you would want to look at opioid-induced anxiety disorder, which would be under the category in the anxiety disorders of substance or medication-induced. And here are the criteria for that. And what you're doing, you can see, is you're indicating whether or not there is an accompanying use disorder as well, or it's just an anxiety disorder. The person's used opioids and it induced the anxiety disorder. The biggest improvement, one of the biggest improvements, is, as I've already said, the text revision, so that now all these sections that follow the diagnostic criteria for a mental disorder have been updated, added to, and I have, again, in red, the association with suicidal thoughts and behaviors is a brand new section that's very helpful. So, for example, let's see here, I just fell open to post-traumatic stress disorder. And what it says is, under association with suicidal thoughts, on page 311, traumatic events such as childhood abuse or sexual trauma increases an individual's suicide risk in both civilians and veterans. And then it goes on to talk about PTSD. And indicators of suicide risk. One of the considered probably one of the most important changes was text changes to bring attention to the cultural, racial, and ethnic factors as that have lead to errors in diagnosis. And so what is there is that there's much more attention to variations in symptom expression, attributions of the disorder's causes or precipitants, and cultural norms that may affect the level of perceived pathology. And with commenting on the risk of misdiagnosis for each particular disorder. The other thing they addressed is gender inclusivity, in improving that in the section gender-related diagnostic issues. They also, part of that is they've expanded section 3, which is about culture and psychiatric diagnosis. And that is, you really should read section 3 to update yourself about how culture and race and ethnicity could really present a different profile that you may, as a clinician, misperceive and misdiagnose. And part of that change is then to change the language you use. As we know, language creates reality. So they want to acknowledge that race, that the idea of race is a discrete natural entity. No, race, the perception of race, is cultural. So they've gone to the term ethno-racial in the text to denote the U.S. Census categories, because the U.S. Census now uses terms like Hispanic, white, or African American. And they want to combine that, just say ethno-racial. The term minority and non-white is avoided in the text because when you use those, you describe social groups in relation to a racialized majority. And doing that suggests and perpetuates a social hierarchy. And then the emerging term Latinx is used in place of Latino, Latina, to be more gender inclusive. In the section about the DSM, about the diagnosis gender dysphoria, they've also made changes in the language about gender and gender identity. So I have here a little chart of what it said in the criteria set in the DSM-5 and what it is now in the DSM-5 TR. So instead of desired gender, it's experienced gender. That is, the person experiences themselves as a particular gender. It isn't about being a boy and wishing you were a girl. It's how I experience myself. They've changed cross-sex medical procedure to gender-affirming medical procedure. No longer do we say natal male, but it's an individual assigned male at birth. And this is acknowledging the fact that, that some babies are born with ambiguous genitalia. And it's always been an arbitrary, somewhat arbitrary decision whether this is a male or a female. So to acknowledge that more accurately, the criteria in the DSM-5 talk about individual assigned male at birth and individual assigned female at birth. Now, we've reached the end of the discussion about the DSM diagnosis and the 5TR. I'm ready to go on to the next section where we're going to talk about reducing diagnostic errors, but we're going to take our break now. And I have 10:30. I'll see you back at 10:45. That's Central Time. Adjust it. So rather than right now, it's 31 past the hour. I'll see you back at 45 past the hour. Okay, are you back? Wow, you guys are really into this. I really like it. I've got lots of questions. So what I did is I'm trying to answer a lot of them in writing, so that and allow it to go to everyone, so that you can see the answers in Q&A that I've given. I still have 5 that I didn't get to. Don't worry. When I have more time during lunch, I'll try to get to those. I'm short of breath because I ran down 2 flights of stairs and back up just to grab something to drink and use the bathroom. So fast break. All right. So the next topic that I want to talk about is diagnostic error. And I alluded to it in that the DSM-5TR text in section 3 talks a lot about cultural, ethnic, racial factors that lead to misdiagnosis. But I now just want to talk about the importance of that we, as mental health practitioners, do things to intentionally reduce diagnostic errors. And then we'll go to differential diagnosis. But, error is misdiagnosis, failure to recognize complications, or in our case, comorbidity. Misdiagnosis, that is, we say they have bipolar and they don't, and failure to diagnose related diseases, again, comorbidity. So let's look at this. Now, in 2015, the National Academy of Science and Engineering and Medicine took on the issue of improving diagnosis in healthcare. Now, this is all healthcare, not just mental health. And as a result of their meta-analysis and study, they estimated that 5% of US adults who seek outpatient care each year experience a diagnostic error. And added to that, that all of us would probably experience at least one diagnostic error during our lifetime. But 5% then, today we've got 167 attending. So that would be 8 of us. Wait, 5%. Yes. That 80 would be 50, 40 of us. Okay. And so I read it and I was really struck by this. And I thought, this was in 2015. What do we know about errors in making mental disorder diagnoses? And I thought, I'm pretty sure it's higher than 5%. So I went and found that at that time, there were just descriptive articles in terms of really good empirical research. And they estimated that 20 to 25% of the clients with mental disorders receive a misdiagnosis, much higher than general. And not surprising because they're very difficult to make, to diagnose. Then I was really delighted in 2021 to find this, that this article had been published. And it was a random sample of 309 previously diagnosed patients who had what they called in the article severe psychiatric disorders and had been given a diagnosis. Then they went to each of those and administered a structured clinical interview, with, the SCID, which is used often in research studies for diagnosis. And their results are pretty astonishing. More than a third of the patients with severe psychiatric disorders were misdiagnosed. In fact, nearly 40%. And so they then broke it down. What actual diagnoses were most misdiagnosed? And not surprisingly, schizoaffective, 75% of the cases. Schizoaffective is like a moving target. Its criteria change in every DSM version. And it can look like depression, it can look like bipolar, it can look like schizophrenia. But the next one, major depressive disorder, 54% of the clients with major depressive disorder were misdiagnosed. I don't know about you, but I find that to be pretty shocking and dismaying. And then schizophrenia was the third most frequently misdiagnosed at 23, almost 24%. And I've given you the reference to that. So I echo the conclusion that was made in the Improving Diagnosis and Healthcare report. And that is that improving the diagnostic process is not only possible, but also represents a moral imperative, a moral, professional, and public health imperative. Therefore, I compliment you. It's a beautiful fall day here in Milwaukee, and hope it is wherever you are, but you've taken the time and invested in improving your ability to diagnose and learning more about differential diagnosis. That's the direction we need to go in, because differential diagnosis using that process greatly improves your diagnosis. So pat yourself. You're spending time. This is not a sexy topic, but you know it's important. So there has been kind of fragmented, disparate research on reducing errors in diagnosing clients with mental health issues. But if we combine those and to their conclusions, there are 3 things that you can do to improve your ability to diagnose and your accuracy. And that is use a structured, intentional process. Now, I do not mean anything like the SCID or, a number of years ago in alcohol treatment, they would have this list. I mean, it was many years ago that everybody had to follow. No, I don't mean that. I mean that you have a structured, intentional way that you organize your intake interview. And you use it with each client. The second is that use techniques to avoid known sources of error in each step of diagnosis. I'm going to share one important technique for each step and direct you towards sources that will help you with that. And then 3, that you always include a differential diagnosis process when you are diagnosing a client. So there's 3 things that we can do, and that's going to be one of the themes as we work our way through today. All right, you ready for differential? I am. So many of us were not taught how to make a differential diagnosis. And I must say that since the time I was an early practitioner, that I think that there is more intent in counseling programs and social work programs and in psychology to teach this as part of diagnosing a client. But I still think it's a little shaky in some programs. So most of us learn by doing. And over the years, I have had come on my own to have what I'd call a 4-step kind of process, intentional. And to boil it down, step 1 is gathering the client's data and doing it in a organized method through the pre-interview collection of info and then the clinical interview. Step 2, I have to identify the syndromes that are present: anxiety, impulsivity, whatever. Step 3 is I have to make a formal differential diagnosis, and there's a process that we'll use. And then step 4, I arrive at my initial DSM diagnosis list. So I also want to credit or say that this isn't just Peggy Bloom's idea. There is a psychiatrist, Dr. James Morrison, who has written a series of books about diagnosis, the first interview. And I usually am not a real fan of books by psychiatrists. They tend to be a little I don't know, the tone, something about it I don't care for, but his are excellent. And he uses a similar process. And if you want to read more, I highly recommend any book by Morrison. And I put a few on your reading list. So step one, we're talking about gathering client database. Database is kind of a clinic behavioral term, but that just you could, if you don't like database, you can say gathering the client's information. So actually, we begin gathering the client's information before the clinical interview or the intake interview. And when the client calls for an interview, they should be asked to bring a list of all the medications that they're currently taking, both prescription and over the counter, to their first session. Do they always do that? About 50%. But you see, more and more, that's a very common thing. I have to take it to my dentist, a list. I have to, of course, to my internist. I had to take a list when I was getting a facial. Okay, so people are more used to it. And even if they don't do it, you're going to ask again during the interview. But by doing this, you have indicated that knowing about the client's medication is an important part of your role and working with the client. Then while they're there doing paperwork, or you can send it to them in advance, but then there's the risk they won't bring it, have them do the age-appropriate level 1 symptom, cross-cutting symptom measure. And we've already looked at that, and I think I even answered a question about that from one of you. And it then becomes, you can also use it as a treatment outcome measure to show improvement. You can use it to monitor at regular intervals during the therapy, and so on. Okay, so now you started your interview, and remember that there are steps in the clinical interview. Different parts you do differently. So, but the whole thing, you've got to do two things in your first hour or your 90 minutes if you're in a place that is really, what shall I say, really focused on getting a good diagnosis. Build rapport. You must build rapport. If you don't build rapport, you're not going to learn information, and the client's not going to come back. And you have to obtain relevant information about the client. You won't be able to make a diagnosis if you haven't gathered the appropriate information. So, what are the phases? The first is a period of intense observation, 5 to 10 minutes. Then about 30 minutes taking a problem-centered, oriented approach, as well as gaining a history. And then the last phase, about 10 minutes or so, is focused exploration. So we're going to work our way through all of this. But what you'll see is that it's really important how you organize the way you're going to gather information and how active you are you alter that in different phases. So we're going to start. I've gone over who I am, what I do, how does therapy work, confidentiality, the things that we do we need to say to orient the client. So then I'm going to start with a brief phase. It's only 5, at the most 10 minutes. And it's a period of open inquiry about the client's concerns and their situation they're in, and to build rapport. So I don't want to intrude, because I want to see who this client is and what they can do. And what they think about. So I will start with a broad, open question. And so develop a few standard broad openings. Your mom filled me in a little bit about her concerns about you, but I want to learn what you think is happening. Let's start by you telling me what you've been thinking about. Or please tell me what problems led you to seek therapy with me. Or I'd like to hear more about, when they tell you something, what else happened? So I'm not guiding the client in a certain direction other than talk about your situation. And as I'm doing that, and I'm observing the client and listening and making kind of a reflective responses, not directive, I am making broad observations about the client's cognitions, their affect and affective regulation, their behaviors, and their physiology. This is intentional. And because remember, I said that DSM diagnoses are built on signs and symptoms that form a pattern. So in the beginning, I want to have a period of intense observation to start to see the cognitions the client has, their affect, their behaviors, and their physiology. And we're going to use this throughout the day. And as a beginner, I recommend that you really focus on, and I know it's hard, it's metacognition, but you're doing two things at once. You're interacting, you're learning about the client, and then you're sorting what seems to be significant in each of these 4 categories. So this phase, short phase, ends when you can decide whether the client can present themselves accurately. That is, they're what we would say cognitively able to talk, their speech is logical. The old term used to be, are you a good historian? It has nothing to do with history, but it just means, do you have memory and you can talk about your situation? Or have you noticed during the interview that the client possibly has impaired communication and or thinking or unusual experiences or beliefs, or they have such heightened affect or depressed affect that I can't count on them being able to present themselves accurately. And in that case, I have to do an assessment of their cognitive status first. Okay, so that's every phase has errors. And the error that I think is so basic, so important, is that as humans, we jump from description of behavior that we notice automatically, immediately, to making a judgment. Now, let's try this out. I have here a gentleman, and he's sitting there across from you in the intake. And what do you observe about this client? And I want you to write down at least 3 things. And I'm going to give you a minute to do it. Okay. So in looking at this client, what did you write down? Did you notice that his face muscles were tense? He seemed tense? Or, the muscles are tense. Or did you say he's angry or he's going to be resistant? Did you write down that he has focused eye contact? Or that he seems suspicious or angry? And how about that hunched posture? Or did you write that? Notice that? Or did you think he's sad and tired? So notice the difference. On here, these are a description of behavior, just the raw behavior. And here is what we just always normally do, is without even thinking and noticing, we jump to judgment of what that means. Now, that's not our fault. It's just the way human brains are wired. It goes back to when we were cavemen and women. And the individuals who survived to have children and pass their genes along were those that could make quick decisions to protect themselves from dangers like predators, high water, edges of cliffs. So you quickly decide, should I run or should I fight? Is this guy coming towards me to shake my hand or hit me with a stick? So the technical term for this is that we foreclose too soon. And if you think about the statement, first impressions count, that acknowledges the fact that I'm going to take a glance and interact with you a few minutes and whammo, I've made a judgment. So knowing that this is what we all do, me too, then we need to to work to interrupt that automatic movement to judgment. And so we have to use a strategy to consciously manage our thinking process when we're doing an intake, and to be able to know what is a description and where have we made a judgment. And that's why I use the categories that I've told you about, the sorting categories, because I'm putting raw behavioral observations in my categories. I'm not making a judgment if I'm doing a good job. Okay, and so to kind of sum this up, I like this Goethe quote: we see what we look for. We look for what we know. It's just another way of saying that our observations are often quickly narrowed down and foreclosed. Now, we're going to practice as we go along. As I've said, we're going to have cases. So as I talk about the steps in the interview and in the differential process, we're going to use a case. And the case we're going to use is Rita. Now, I have included in as handouts the full copy of each case, but for our purposes right now, it's easier for me for you to see it. And what I'm going to do is I'm going to read it out loud, and I want you to follow along with me. Read. And as you're reading, I want you to start to sort. And start to note things that in what Rita says or shows, what symptoms she describes, things that about cognition that seem significant, about affect, about her behavior, and about her physiology. And a true behaviorist would not have that category physiology because that's behavior. But I do this because unless you are trained in the medical profession, one of our areas is we're too psychologically focused. So we forget that physiological signs and symptoms are really important, as is knowledge of medical conditions and so on. So I separate that out to remind myself, even though my initial discipline was nursing, I have 2 degrees in nursing. At this point, it was so many years ago, I sometimes forget myself. Okay, so let's go back to the case and take out a piece of paper and make 4 columns and we'll be using that in a minute. Rita is a 31-year-old single white female auxiliary police officer, and she arranged an appointment at the mental health clinic at the urging of her physician. The physician's referral noted Rita was quite tearful and angry about her pain and lack of recovery when she came in for her recent medical appointment. The physician thought a mental evaluation was indicated. Rita shuffles slowly and laboriously into your office, lowering herself with great care into a chair. Wearing a neck brace, she is neatly groomed, with shaggy brown hair, dressed in a t-shirt, sweatpants, and Crocs. Once settled, Rita states that she has constant pain and muscle tension in her neck and back since she was injured 7 months ago. She relates her experiences with vivid detail and anger at her assailant. November 23rd, the day that changed everything, I had just finished writing a parking ticket and placing it on the illegally parked car when a man came dashing out of a barber shop swearing and then hit me in the jaw so hard I fell back on the pavement. My partner on the other side of the block rushed to help me and called 911. Once at the ER, X-rays revealed a hairline fracture of the jaw. The fracture did not require her jaw to be wired, but Rita was placed on a soft diet for 4 weeks and given a 30-day prescription of Percocet, which is 5 milligrams oxycodone plus 325 milligrams of acetaminophen in a tablet for pain relief. After 1 month, Rita's primary physician and the consulting spine specialist found her physically fit to return to work. However, Rita states she continues to be unable to work because her pain is so severe. She can barely stand or walk for more than 20 to 25 minutes. Because of this, she must sit or lay down most of the day. She says, "These doctors keep telling me I'm good to go back to work and I don't need a neck brace or to continue pain medication," she says with visible anger, "but they don't know what I'm going through." Her voice breaks and tears well up in her eyes. "They don't believe me. They think I'm lying." Okay. Now, I want you, and I'm going to give you a couple minutes to write down the things on a piece of paper in 4 columns that you think that just from this brief sort of phase 1 of the clinical of intake, you've learned about Rita. That's significant. Okay. Now, if we were all together, I would go around the room and I would collect some of the things you put, but we're not. So what I've done is I've done the worksheet and jotted down and put down things that I thought were significant in that first segment of talking with Rita. So let's start with cognitions. Now, when we look at cognitions, we should think about what is the thought content. In this case, she's really negative about medical treatment. And then we also look at thought process, how the individual thinks. And so she's understandable and she seems able to recall events and dates. Now, in affect, I'm looking at verbal and nonverbal signs and symptoms. And so I notice she has an angry tone and she becomes tearful. Under behavior, the behavior can both be what the client reports and then what you observe during the session, or if it's a child and you use an informant. So she wears a neck brace, she moves cautiously, and she's not working. She's not gone back to work. Under physiology, again, reported by the client and what you observe in the session. She says she has pain in her neck and back. I noticed that she does seem tense, and her muscles are tense, and she takes Percocet for pain. Okay, so we're now ready to make that decision. Do we have enough of a behavior sample for Rita to know, do I need to begin with a mental status exam, or is she a good enough, can she present herself accurately enough for me to just start with a presenting issues approach and just weave in checking the mental status as we go along? So what's your vote? I say that she is able to present herself accurately. Even though she's a bit negative, she's understandable and can recall things. So I'm going to say I'm going to go to a presenting symptoms approach in phase 2. So in phase 2, that's the biggest part of the intake interview. And that's where we're trying to understand the whole client. And so I'm going to be continuing to gather data in a somewhat structured way and build rapport. So now I'm exerting a little more direction on the interview. And as indicated, if I need to, this section starts with the appropriate age level mental status exam, and then going on to presenting concerns and history as much as possible. Or if, like Rita, the client seems to present himself accurately, then I'm going to begin with the client's presenting concerns, and this will be a broad exploration about the client's life. Okay? But if the client is 65 or older, then it's recommended that you use some form of mental status exam during the intake to detect mild cognitive impairment. So even though Rita doesn't need, we're not going to do a mental status formally with her, I want to take a moment to talk about brief mental status exams that you could use. Now, and depending upon your clients, and we all are somewhat familiar with the mini mental. I don't seem to have a line there. Wonder why. Okay, there I do. Okay, the mini mental state exam. You know that one. It's where you count back from 7 and you put the hands on the clock. You remember words. Okay, and the truth of the matter is that the mini mental status exam only picks up fairly gross pathology. That is, the person has a neurocognitive disorder. And so, and so you aren't going to be able to tell if they have some normal cognitive decline or mild cognitive impairment, which would start to impact your intake if you just use the mini mental state exam. So I'm going to suggest that you think about, if you work particularly with older persons, that you start using one of these two. The St. Louis University Mental Status Exam has a terrible acronym, SLUMS. I have provided a copy of this in your handout. And the SLUMS was developed as a joint project between St. Louis University and the VA. And it's provided free along with instructions by Googling it on the web. You can get the information. And the advantage of the St. Louis is that it will pick up mild cognitive impairment and differentiate it. It gives you 2 levels, it and neurocognitive disorder. But also, very important, is that it has norms for these 2 types of impairments related to your education, because embedded in mental status exams is people who have less than a high school education will score lower, even though they're not impaired. And that has to do with a couple of things. One may be funda knowledge, but really what I think it is the intimidation of anything that seems like you're being examined. It's sort of like school. So you really want to, if possible, pick something like this, which you administer verbally. And it also has the advantage of scoring. So it isn't just yes or no, they could do it. You get a score for certain parts of doing it. The sort of Cadillac right now of brief mental status exams is the MOCA, which is the Montreal Cognitive Assessment Test. I don't know if you remember, but if you remember the interview that Chris Wallace had with President Trump when he was talking about his annual checkup and how he took this exam and he was explaining, you had to answer words. He took the MOCA. And the MOCA, it has both full and brief forms. It it's scored. It has a form to use with someone who is illiterate. So you can read it, or all of it, or it also has for people with 5 years or less of education. So they use different forms. And it will give you a score that the person does not have any impairment. They have normal cognitive decline. They have mild cognitive impairment, which is a Z code, or they have neurocognitive disorder. Now, the mini mental and the slums are free. For the MOCA, which is much more sophisticated in picking up mild cognitive impairment, and you do need to pay an initial $125 to become certified to use it. Then you have access to all the forms, and you score it yourself. I have done that because I really wanted to be able to know how to use it and use it effectively. Now, so let's go back. We've done the mini mental, and we go on. We brief mental status. We go on now to presenting symptoms, or we just continue to watch for things related to cognitive functioning, but we take a presenting symptoms approach. So we start to ask the client more things, broad questions about their presenting concern, which they've described to us in phase 1. So we want to know the history, what is their developmental history, their social economic background, and to have any previous mental health treatment history, any physical symptoms or medical conditions. And I always ask, when did you have your last physical exam? And we'll see when we get to specific disorders how many medical conditions can appear as mental disorders. So we need to, if they haven't had a physical exam within the past year, I request that they get one. They share the results with me. Ask the physician or the PA or the nurse practitioner, give them permission to share with me. Then family history, and this is family history in terms of mental disorders. And then, of course, we ask again about medications, over-the-counter, alcohol, tobacco, illicit drugs. All of those we would have gotten on our intake form. They fill in the pre-interview, but we ask again because research shows that if we both ask for it in writing and then go over it again verbally, we're going to get more information about drug use. Now, as I'm doing this, of course, this whole time, I continue to organize these observations, symptoms, and other data by category: cognition, affective regulation, behavior, and physiology. So this is going to take about 30 minutes. Now, there are errors in phase 2. And the one that we've become more and more aware of, and as I've already noted, is discussed in section 3 of the DSM-5 TR manual, is that we may misinterpret the client's symptoms and data because of either our cultural bias, and we all have some bias as a result of growing up in a given culture, and or our lack of cultural experience. For example, when I was just finished my master's program, I grew up in the Midwest. I went to school in Buffalo. Then I got my master's in nursing in San Francisco. I took my first teaching position at the University of Hawaii. And all of a sudden, having grown up in a largely white, middle class, lower, so working class area of Ohio, and even in Buffalo, I had no African American student in nursing school with me. That I was now in Hawaii in a place where I just had no cultural experience. So I had to learn right away that I have to take into account what the client's self-presentation and symptoms, how they were being influenced by the many different cultures that are present in Hawaii. And you do too. So how do we avoid imposing and misjudging signs and symptoms? Well, we have to take action to reduce our cultural bias and lack of information. One, do things to increase our multicultural knowledge and competencies. So more self-awareness about my own cultural identity and what influenced me. In the Midwest here, we all have kind of a Germanic influence because over 50% of us are part German, so that means we're a bit stoic. My other part's Scot, so they're add in some more. Supervision of your clinical interviews, getting help, supervision, even after you graduate. One thing we did in the small part-time private practice I was in is every month we did group supervision where we actually worked on each other's tapes and talked about cases. Seeking continuing education about counseling specific minority groups. And I see offerings all the time for continuing ed. Then make changes in your clinical interview, adjust it to be more open. And so in the DSM-5 TR, there is the cultural formulation interview, and it has been really improved over the one the 5 introduced it, but now they've really improved it. It's in the back of the manual, and it gives you prompts and ways to ask questions that will elicit more meaningful thoughts about the client's symptoms and presentation. And then learn to conduct culturally responsive assessments. And I highly recommend the book by Hayes. It's available from the American Psychological Association Press. And in fact, you can get CE credits for reading it and taking the exam. It's addressing cultural complexities in practice, and I've included it on the reading list. So, okay, so now we've done phase 1 and phase 2. We're at about, 40 minutes? And now we need to move to phase 3. And this is the mistake a lot of people I see make, particularly when you're a beginner, is that you don't do phase 3. And what we do, and it's really important to be able to make a diagnosis at the end of this one session. And that is, you take a minute and you think, what are common symptoms and syndromes that the client hasn't offered or discussed in phase 2, or I haven't asked about yet. So how we do this, we look at the cross-cutting symptom measure and notice if there's anything that the client might have marked on it but didn't tell you more about. Now, clients, there are some things they don't talk about. Things that may make them look crazy, things like sexual abuse and incest, things about behaviors like gambling or so on. So what I need to do is I need to make sure I have covered at least a focused question on categories that we've not approached in phase 2. And I have given you a handout, a one-page handout of prompts for each of the DSM categories, i.e. syndromes. Categories, classification, syndromes. They're kind of similar to each other when I'm talking. I also have, if I've gotten a referral and there's something in there that the client hasn't talked about, I need to ask. And then I need to decide if, before I can really make a diagnosis, I need to speak with a family member or another informant. So the clinical interview is done when I am now confident that I can cluster everything I've learned, all the observations and symptoms of what it seems significant, and I can put them into possible syndromes. Okay, that's phase 2. So let's move on. But before we do that, let's review what we now have added in our information about Rita as a result of having conducted phase 2 and 3 of our intake interview. And again, we're going to do the same thing. I'm going to read it. I ask you to read along and also make note of what is significant in terms of cognition, affect, behavior, and physiology. 3 months ago, when the police department refused to give her more sick days or approve workman's compensation, Rita consulted an attorney. She says she wants to return to her job, but physically is not up to even the lightest office work. On her own, she has seen a physical therapist, an oral surgeon, and an acupuncturist. and none of these professionals could identify the cause of her pain in her neck and jaw, and their treatments and back did not give her relief. Rita continues to take the Percocet every 6 hours. She states she uses it as prescribed, but is not willing to taper off as her doctor suggests, due to the persistent neck pain. Since high school, Rita smoked marijuana daily, and she continues to do so. One joint that I take hourly puffs from softens my pain and helps me relax. As she can't join her friends after work anymore, she has not drunk alcohol and denies use of other illicit drugs. Rita sleeps on top of a bedboard on her bed or in her recliner, often finding it difficult to fall asleep, or once she finally falls asleep, the pain wakes her up several times before she finally gets out of bed around 9 a.m. Rita reports that in the last month, she forgets to eat, but she isn't hungry anyways. Co-workers and friends reached out after the incident, but lately, Rita thinks they seem less sympathetic. She lets calls go to voicemail most of the time because she does not feel like socializing due to the pain. When asked about her mood, Rita said, "I don't know. I really feel mostly dull. Maybe I'm depressed." She's beginning to feel hopeless of any possibility of living without neck and back pain and wonders how she can live without being able to work. She thinks what kind of bad life this would be and about just giving up, but denies thoughts of suicide because of her Catholic faith. She has never sought mental health treatment and does not recall ever being depressed prior to the incident. She describes being down in the dumps as a family trait, but is not aware of any mental illness in the family. She had one meaningful romantic relationship 3 years ago, and until the injury, dated off and on. Okay, so now we need to add to the notes we already have. And so I'm again going to give you a couple minutes, and I want you to jot down the additional important info you have on cognitions, affect, behavior, and physiology. And remember, we put this down in just the descriptive behavioral observations. Okay, so again, well, I hope you've written some things down, and here is what I added, and there's sort of a little white line if you can see it. So now I know she thinks she couldn't manage any form of work, and friends have become less sympathetic. She thinks she should get workman's comp. She worries the pain will never end and she'll never be able to work. She thinks life is bad. She considers giving up, but she denies thoughts of suicide. Under affect, I've added that she says she feels dull, hopeless, and maybe depressed. Maybe, she says maybe. Additional behaviors, she's gotten an attorney. She's made many appointments with health professionals. She continues to take Percocet and not taper off. She forgets to eat. Her problems are, she has problems getting to sleep and staying asleep. She's not answering the phone, and she has less contact with friends. She sits or lies down most of the day, and she smokes cannabis daily. Under physiology, I've put the difficulty getting to sleep and waking up in the night. The pain seems softened by the cannabis, and she has found no the doctors that she's gone to have found no physiological cause for her continuing pain. Okay, so we've got the picture here, a bigger picture. And so what we have to do is we've got to identify syndromes. And how we do that is that we look for patterns. I particularly look for patterns on the behavioral observation list I've been making. Now, do I make it down in writing? Not anymore, because I have a lot of practice. But there are times when I do. One, I've got a client, and honest to God, their presentation is so confusing. I just really don't know what's going on. So I use the behavioral observation sheet to really focus in on categories of symptoms: cognitive, affective, behavioral, and physical. I use it when I supervise, because one of the things I've recognized over time is that people I'm supervising, again, may not be seeing the whole picture. And I want to make sure, and I'm doing two things. One, I'm helping myself know how to work with and talk about the client and help the supervisee understand. And two, I'm modeling the use of this process. So, you can do it either way. But there are times when you really got to write it down. Then, or I can also look at the cross-cutting symptom measure. Remember, it's kind of keyed, and see if there's any area that they endorse and get a higher score on. What are the syndromes? And then maybe from their developmental, psychosocial, or mental history, I've got some other additional information about syndromes. Okay, so as the reality is that this, to do this requires knowledge of the key symptoms for each category of mental disorder. You don't have to memorize the criteria set for specific disorders. Thank goodness, there's 298. But for each category, like depressive disorders, psychotic disorders, dissociative disorders, I need to know what would be the key symptom pattern for that category. Because that way I can recognize symptom patterns. Now, I'll get you off to a good start today, because when we get to each specific area, that's what we're going to be emphasizing. So this step ends, differential diagnosis ends, when you have identified all the syndromes that seem to be present. So turning to Rita, here we have the list that we've generated. And now using the list, you need to identify clusters of symptoms. And so I'm going to give you, because I'm running a little slow, I'm going to, I want you to see if you can recognize a syndrome. What are you thinking about? What pattern of symptoms are you seeing? Okay. What syndromes are present? Well, here's the ones that I see present. There's chronic substance use, both opioid and cannabis. Her thoughts, feelings, and behavior are focused on her physical condition, particularly the pain. I see the syndrome of depression, the negativity, the tearfulness, feeling dull, feeling hopeless. She says she's depressed, not eating, problems sleeping. And then she definitely has problems with work and her social environment. She's not working, and she's dropped back. She's become socially withdrawn. Okay, so those are the syndromes that are present. A different client, we would have a different set of syndromes. So now, like everything else, in step 2, there's a source of error. And this can happen over and over again. And I get a client, and a previous diagnosis shapes my view of the client's diagnosis, or I end up foreclosing too soon and not identifying that actually there's other patterns present. So here are some examples that I've actually encountered in clients that I've worked with. The client reports, I'm bipolar. You don't have a referral that says that. She's never been treated for it. And you know what type of client often thinks they're bipolar? Someone who is borderline personality disorder, because it explains that they either love you or they hate you. And so it may, as this notion of being either or fits for them. So you got to be careful about client reports, self-reports. The mother says the teacher thinks he has ADHD. Teacher is not qualified to diagnose, but certainly sees the child So, but I've got to make my own judgment. The medical referral is that for the client having panic attacks. I can't tell you, because I worked a lot with clients with anxiety. This happened a number of times. And what it is the client has told the physician or the nurse practitioner that they have panic attacks. But what they mean is they get a lot of anxiety. It isn't necessarily a panic attack, which has a distinct set of criteria. And so I have to check that out for myself. Another one is maybe notes from prior treatment, such as, a prior diagnosis like of schizophrenia, which we all know is kind of a chronic, permanent kind of diagnosis, and in most people. But is that really what the situation is? Because we know there's a whole spectrum, the schizophrenia spectrum, and maybe it was that has somewhat different treatments. And then there's bipolar. So here is the mistake, is letting that shape you. So how do you reduce it? You have to always conduct your own complete assessment so that you have a current database that you're using to make the diagnosis. And so that you're using your behavioral observations and what you learned during the intake to look for patterns rather than hop to a diagnosis. So now we're down here to step 3. We're going to do the differential diagnosis. Hang with me. We're going to eventually get to the categories, which I know gets a lot more interesting, but this is so important that you understand how to do this and feel confident in doing it. So differential diagnosis is actually a 2-part process. And we do it before we make a diagnosis. Maybe you've seen physicians write a diagnosis and then they write rule out, which kind of makes you think you do that after. But that's not a differential diagnosis. What we're doing with a differential diagnosis is we're starting by thinking about all the possible diagnoses that have as part of their criteria set one or more of the client's syndromes that we've noticed. Okay, so we're starting, and if you think about it this way, we're starting broad. So call this the possible list. And there are certain things about this list. One, follow the Othmer rule of 5. Othmer and Othmer were a husband and wife. They were both psychiatrists. And for DSM-3 and DSM-4, they wrote companion books on intake interviews and diagnosis. And their rule has stuck with me, and I find it very valuable. And that is, for every client, always say to yourself and think, what are 5 things, 5 diagnoses the client may have. Now, there's nothing magical about 5, but it's easy sometimes to think of 1 or 2 more than the one I'm thinking of the most. But 5 pushes the envelope. And that's what we got to do on this list. Another thing is that we need to always, on our differential list, consider the use of substances. That could be medications or drugs, toxins, that could be the source of the symptoms. And consider the medical disorders that could cause the symptoms or make the symptoms worse. So you include that on your list. And then you want to use other resources to help you identify possible diagnoses. Now, what resources? Well, I mentioned earlier that the DSM-5 TR manual has a section for each diagnosis where it discusses and provides a list of possible differential diagnoses. Okay, and it's in the section labeled differential diagnosis. So let's do one that we're probably not going to talk about otherwise. Let's turn to dissociative amnesia on page 340, 341. Now, this material is only in the manual, not in the desk reference. So I'm going to turn here. And I've in the section dissociative amnesia, and I'm looking at differential diagnosis. Okay, and so it says it talks about dissociative identity disorder, then post-traumatic stress disorder, neurocognitive disorder, substance related. And in each one of these possible explanations for this kind of symptom pattern, let's look at under post-traumatic stress disorder. Some individuals with PTSD cannot recall part or all of a specific traumatic event. When that amnesia extends to events beyond the immediate time of the trauma, a comorbid diagnosis of dissociative amnesia may be warranted. So it says, here's what's important in this other disorder, in addition to the the syndrome of amnesia. And what's really nice about this is it's listed in order of probability. So for sure, in differential, you've got to, in terms of dissociative amnesia, you've got to think about dissociative identity disorder, then PTSD, then neurocognitive disorders, substance-related disorders, and trauma. Okay, so, but it's in order of frequency that's what it is. That's one resource that is really important to help use. So here we have a differential diagnosis list, and we've recognized that the syndromes present are depression. There's a focus on physical symptoms. there's substance use, and there's interpersonal relationships and work issues. Now, what I want you to do is I'm going to give you 3 to 4, I'll give you 4 minutes. And I want you to list at least 5 other 5 diagnoses that this could be, that Rita might have this disorder. And you might want to also, for help, look in the very front of the book. There's a section that's not in the Roman numeral page numbers of the DSM-5 classification. And then that'll help you see related disorders. So now we're not talking about broad categories. We're talking about particular disorders that Rita might have based on the pattern of syndromes. All right. I hope that you've been able to generate at least 5. So here is what I've come up with. And I have major depressive disorder due to another medical condition, medication-induced depressive disorder, adjustment disorder with depressed mood, cannabis use disorder, opioid use disorder, somatic symptom disorder, and PTSD. Now, so notice that what we're doing on our initial differential diagnosis list is we're listing all possible. It's the client might actually have more than one. So this is not like an either or situation. This is what might possibly be present, what disorder or disorders. So all of these in their criteria set have at least one of these identified syndromes as part of their criteria set. Now, in addition, another one that some of you may have thought of and is also something that you might want to think about because workman's comp is involved in it, is malingering. And then that she has an occupational problem, that's a Z code. She has threat of job loss because she really does need to get back to work, doesn't she? Okay, so we came up with quite a long list. Okay, so let's move on then. We've got our possible list. And now the other part we have to do in the differential is now take that broad list and start to narrow it. So we're going to move from possible to probable. And we do that by looking at the diagnoses and removing from our list diagnoses where the client's symptoms clearly don't meet the full criteria set for that disorder. And there are actually aids for this as well, and that is it's published in a book, the DSM-5 Handbook of Differential Diagnosis. And it's available as an app as well as a hardcover book by First. And it contains 2 sets of ways to help with it. One is a decision tree approach, and the other is comparison tables. Now, I'm going to show you the decision tree approach, which is sort of the mental process you go through. And then we're going to use comparison tables when we get to the specific diagnostic categories. So here's an example. Okay, all right. So I want to go back to that for a minute. So do you need to get that? No, if you don't do intakes more often than maybe once a month and you work with your clients a long time. However, if you do intakes regularly, crisis team, ER, receiving unit, then I would recommend that you either get the print copy or the app. So far, they have not come out with a revised version of this for the TR. And I see no indication they plan to. Really, because the TR doesn't make huge changes in terms of the actual criteria sets. We've gone over those. They did change it. I don't think that this will, if you got the 5 version, there'd be any inaccuracies other than prolonged grief disorder. All right, so now here's our list, and we've got to start narrowing it down. So where do we start? Well, I'm going, let's, some of these ones further down here, we really better figure out, given that it was a traumatic event, does she have PTSD? Okay, so if we look at PTSD, we see that she doesn't have the intrusive thoughts and the and nightmares and avoidance. At least we don't think it's avoidance of where it happened or anything like that. So she doesn't really meet the criteria. Okay, now the depression. Notice that we have 4 different mental disorders that could be the possible diagnosis. We got to reduce that. So let's get some therapist's favorite, adjustment disorder with depressed mood, and check it out. And that adjustment disorder we're going to discover, is not meet the criteria. Why? Well, you know, a lot of folks, when I ask this question at a live workshop, say it's because it's been going on too long. But actually, that's not the reason they don't meet the criteria. So adjustment disorder is in the category of traumatic and stress-related disorders. So let's take a look at that. It's on page 319 is the criteria set. If you'll turn to page 319, if you have your manual. Okay, so there's emotional behavioral symptoms in response to an identifiable stressor. It began within 3 months, yes. Marked distress out of proportion to the severity or intensity of the stressor. No, not so sure. There is significant impairment, though, in functioning. So that's yes. The stress really does not meet the criteria for another mental disorder, That's C, and it's not merely an exacerbation of an pre-existing mental disorder. That's the one it doesn't meet, because she does probably meet the criteria for another mental disorder that has a similar symptom profile. So we have here major depressive disorder. Now, depressive disorder due to another medical condition and medication-induced depressive disorder. You can only diagnose one of these three. So before we look at major depressive disorder, let's be sure it's not related to a medication or a medical condition. So I'm going to, like medical condition, I'm going to say no, because what did that move? It's supposed to go off. Hang on. There we go. Because she's been seen by lots of doctors. And so the truth of the matter is that you don't get, depression is not triggered by the physiological effects of a fracture. Okay, so that we got that. How about medication? I noticed in the question someone has already asked about that. Okay, so yeah, it's true. She's been on an opioid for a long time. And can opioids induce depression? Yes, they could. But I happened, by luck, to be married to a pharmacologist who studies psychotropic meds. And he says that the dose is not high enough it probably gives her constipation, but probably not depression. Have symptoms of a depression. Because essentially what we're saying is the medication causes side effects, but they're an effect of the drug, and that is the change biologically that is a depression. Can be related to heavy use of opioids, but she isn't using enough. Okay, so if we look at we look at major depressive disorder, it fits. So how about, well, let's look at the use disorders. Opioid use disorder. Yeah, she's been taking it for quite a while, but you know what? She doesn't meet the criteria. So if we look at page 608, and page 608 is the opioid use disorder. And if you look at A, there's the pattern, and you'll notice that they're not taken in larger amounts. She doesn't want to cut down. She doesn't spend a lot of time in activities to get it. She's got a prescription. She might have a desire to use it. That's maintaining it. I wouldn't be surprised. But what's going to rule this out is criteria 10 and 11. And that is the note that criterion A, tolerance, is not considered to be met for those taking opioids solely under appropriate medical supervision. And it says the same about withdrawal. So perhaps the diagnosis is that the physician would rather keep writing the prescription than have her go out in the street, and if she indeed had one. But at this point, we cannot diagnose the cannabis use because she's taking it as prescribed. Cannabis use disorder, if we look at 575, is where the criteria for that are. And here, it's a very confusing picture. We know she's been using cannabis for a long time, and she uses it daily. What we don't know is we didn't collect enough information to see if it's a problem. It's a problematic pattern. Now, we have noticed social withdrawal, which can happen. We don't know anything about how she gets it, how long if she takes more than intended. We don't know the answer to any of these. So at this point, I'm going to leave it on, but recognize that I've got to get more information about this. Then we have, okay, so we've addressed that, and it's a possible still that we've got to keep considering. Okay, malingering. No, she does not meet the requirements for malingering. Somatic symptom disorder we haven't talked about. And that is one category of symptoms of disorder that has been really changed between the 4 and the 5. It really changed. And so some of you may not be as familiar with it. So let's turn to the somatic symptom disorder, which is section, which is, I got it almost there. On page 351. And somatic symptom disorder has incorporated several other somatic disorders and put them into one category. And so if we look at the diagnostic criteria A, one or more somatic symptoms that are distressing or result in significant disruption of daily life. Yeah, her pain and not being able to move. Well, excessive thoughts, feelings, or not be able to stand. Excessive thoughts, feelings, or behaviors related to the somatic symptoms as manifest by at least one of the following: disproportionate and persistent thoughts about the seriousness of one's symptoms. Yes. Persistently high level of anxiety. No, I don't think she has that about her health or symptoms. Excessive time and energy devoted to these symptoms or health. Yes, she's gone to multiple doctors. She has little routines. She lays on a bedboard. Then C, although any one somatic symptom may not be continuously present, the state of being symptomatic is persistent. typically more than 6 months. Yes, it's persistent. And then notice it says specify with predominant pain, if with predominant pain. And when you see this, it says specify if, then you only give it as part of the diagnosis if it indeed fits. And so in this case, she does have predominant pain, which in the 4 was called pain disorder. And this is for individuals whose somatic symptoms predominantly involve pain. Okay, so we're not saying she doesn't have pain. We're saying that she focuses on it to the extent that it has become dysfunctional and is a somatic symptom disorder. Okay, so we've now narrowed our list. Yes, we agree with the occupational problem. So now we've got our so we now have our probable. This right here is our probable list. It's our final differential list. And we're ready to make the initial diagnosis. And remember, diagnosis is a list. So what we have to do is now we take our differential diagnosis probable list and we carefully, before we just kind of did a quick look at criteria, now we're going to carefully verify that each of the diagnoses on the list, indeed the client meets the criteria. And if you are or in the case of the cannabis, if you are quite positive that it's present, but you need more data to confirm it fully, then you're, as of the DSM-5, you've been allowed to add provisional, in parentheses, on the diagnosis, after the diagnosis name, and put it down as a provisional diagnosis. Then, of course, if it person doesn't when you get more information, meet the criteria, then you remove it. Or you substantiate it and you keep it there. And then we make sure we've got the right number, we've got the right level of severity and then we assign the appropriate code. So here we have our probable diagnoses, and here we have our initial list. Somatic symptom disorder with predominant pain, moderate. Major depressive disorder, moderate. And I used the criteria given in that section for what was mild, moderate, severe. Cannabis use disorder, provisional. And threat of job loss, which is a Z code. However, I'm not going to, even though this might be the initial list, I would not do the cannabis. And the reason for that is that any substance use disorder diagnosis is a permanent diagnosis. It stays with you. What varies is the specifier. And so if you're no longer using and it's been for a period of time, the specifier would be in sustained remission. However, it's a permanent diagnosis. So I don't trust people, quite frankly, especially with third party, to see that I've removed it if they don't meet the criteria. So why put it down until you're absolutely sure? So for right now, I would not include it. So this is my final list, excuse me. So we made it all the way through. The only other thing we've got to think about, excuse me, is comorbidity. And actually, Rita has comorbidity, and we've recognized it. But sometimes we find we have serious symptoms that our diagnosis does not account for. And so in that case, we've got to think about, is there some comorbid disorder that I've missed? And in this case, we have to really think some more, go back and look again, because comorbid disorders create treatment problems. They determine the scope of treatment, how the course of the treatment, it lengthens it, and the prognosis, it often decreases it. So it's really important to recognize comorbidity when it's present. The disorders that are most frequently comorbid are the depressive disorders, the substance use disorders, and anxiety disorders. Okay, it is now lunchtime. And I encourage you to take a break, move around, go eat, think about what we've talked about. And when we come back, we'll come back at and so it, like now for me it's 12:52. I'll start again at 2:00. So we're taking a little over an hour lunch break. So depending on your time zone, be back in an hour 10 on the hour. And I'll work on questions and I'll answer those when I get back. Have a good lunch. Well, welcome back. I hope that you've had a good, nice break at lunch. And what I'd like to do before we launch into our afternoon, where we're going to be looking at differential diagnosis for specific syndromes and get more down to the nitty-gritty of of diagnosing specific mental disorders, I thought I would like to answer some of the questions. Now, what I've done is I've answered 20 questions in writing, and I hope that you're able to see those answers. Then there are 4 that I'm going to answer because it's going to take a little bit longer than that, and I think they're important. 2 of the questions are about when to use other specified and unspecified and etc. Okay, so if you will turn, there actually is a description of these. So what we're going to talk about in answering this is that there's something they call degrees of certainty or levels of certainty in diagnosis. If the individual meets the criteria, you give them the diagnosis. If the individual, you're quite sure the individual has the diagnosis, but you need to collect a little bit more information, then you use provisional. And the description of using provisional, when and so on, is on page 24 in the manual under the topic provisional diagnosis. But what if we've totally collected all the information there is, and the client does not meet all of the criteria for any of the diagnoses in a particularly broad area, let's say anxiety disorder. But in that category of anxiety disorders, the client does not meet any criteria set, but you're quite sure that it is a disorder of anxiety. So you have the choice then of diagnosing that other specified anxiety disorder. And then in your notes, you say what is missing or how the client doesn't meet the criteria of a specific anxiety disorder, but you're sure it is. Then there is a even less certain category called unspecified anxiety disorder, if you can do that, or unspecified mental disorder. In that case, you do not have to supply information about what's missing. Now, word of advice on that, if at all possible, if you are dependent on reimbursement for your work, do not use unspecified. Because just like NOS, not otherwise specified, or adjustment disorder used to be red flags for turning down claims, unspecified mental disorder runs that risk. Now, so that is those two are described in terms of how you use them on page 22 of the DSM manual. Now, how they appear when we look at depression, which will be one of our first, it'll be the first syndrome we do. I'll show you where you find other specified and unspecified in each category of disorder. Okay. Another question is, and for the person who was asking about prolonged grief disorder, it talks about seeing the catch-alls. Actually, what you were looking at was that it's in the category of trauma and stress-related disorders, and you were looking at those diagnoses we just talked about of other specified trauma and stress-related disorder and unspecified. So it isn't murky with prolonged grief disorder. Here, Michael asked, should we always include a mental status exam inclusive with the presenting interview? We need to talk about formal mental status exam, which I shared 3 different ones, and the fact that you need to be aware of the elements that indicate cognitive functioning when you're not doing, if you choose not to. Quite frankly, doing a mental status exam, stopping and formally doing one with a intact person that is cognitively intact is off-putting. And remember, we're trying to build rapport. And I don't know if you've ever had to have someone ask you to do a mental status exam. I have, and it was over the phone because my husband and I had filed for long-term disability insurance. We wanted to buy it. And part of the phone interview was a mental status, and I couldn't believe how freaked out I felt, anxious, even though I could do it. So you do not always do a formal mental status exam. You only do that if you have concluded during phase 1 of the interview that the person has some issues, either in terms of language, thought process, or heightened affect, or that is going to interfere with their ability to judge things. Then you would do the formal. And then in terms of just asking, you listed behavioral observation sheet referenced in slide 54. Is this the chart? I missed the answer. Slide 54. The behavioral observation sheet is just you taking a piece of paper and making those 4 columns. It's just a sheet that you use to take down and separate as you think. Sometimes you're doing it in your head. Sometimes you're formally writing it down. Well, again, I love how many questions you're asking. It tells me that you're quite involved, and we'll go from there. Let's see. I think I've got everybody that I was going to answer. Okay, and the rest of you I've sent written answers. So now we're ready to look at take what we've learned about the differential diagnosis process and see how it plays out with some of the major categories of disorders in the DSM. And we're going to start with depression, dysphoria. And I'm going to take a little bit longer with this one, and because we'll end up using this same format when we move on to anxiety, psychosis, and so on. So I'll do a little more explanation of why we think about these things as we do depression. So first of all, remember I said that there's no way around memorizing the key symptoms if you're going to be good at making a diagnosis. So with depression, if the pattern you see, like we did with Rita, is depression, then we have the presence of sad, empty, or irritable mood, accompanied by somatic and cognitive changes that significantly impact the person's capacity to function. Took that right out of the beginning of the chapter in the DSM on depression, depressive disorders. So that is the pattern we have to look for. We have to look for the mood, sad, empty, irritable, and somatic changes like eating or not too much or not eating, the sleep changes in sleep, and then cognitive changes, which would be the negative, and so on. And so then what I did is, okay, let's look at what are the key symptoms that are listed on the DSM-5 TR's level 1 cross-cutting symptom measure. And we see that there's 3 items: little interest or pleasure in doing things, feeling down, depressed, or hopeless, feeling more irritated, grouchy, or angry than usual. And those of you that work with children, adolescents know often that is one of their key symptoms. Then I also went to items on the level 2 cross-cutting measure for depression. So what I'm saying is, and we're going to do this for each one of these, depressive disorders, depressive is a syndrome, a category. And in it, when you see this symptom in a client along with other symptoms on this list, then you should be thinking, oh, the client has a syndrome of depression. So on level 2, in the past 7 days, I felt worthless. I had nothing to look forward to, helpless, sad, like a failure, depressed, unhappy, and hopeless. And then on the level 2, they list the intensity. So that's the pattern then that you would recognize. So now let's talk about differential diagnosis when you have one of the syndromes is depression. And so as I said, when we were looking at differential diagnosis, you always have to consider if this cluster of symptoms, this depression and dysphoria could be due to the physiological effects of a substance. And so here are substances that are known to induce a depressive disorder. And so among the drugs of abuse, we have alcohol, hallucinogens, inhalants, opioids, sedatives, hypnotics, and stimulants, corticosteroids, and hormones. Now, I see what's wrong. That should have ended with stimulants. Then on the next line, I don't know what it hopped on me, corticosteroids and hormones. So let's talk about the drugs of abuse. How do I know? Where did I find out this information that these could induce? Well, if you would turn to page 3, it's right at the start of the drug substance use disorder section. And so that's it on I want you to go to page 545. And this chart, which is a chart of all, it says diagnoses associated with substance class. This chart is also in the desk reference at the start of the section on substance use disorder criteria. So how this chart works, and I want you to be sure to go look at it, is if you don't have it with you, is down the left-hand side, it lists all the categories of substances. So, for example, alcohol, caffeine, cannabis, hallucinogen, all the way down to tobacco. Okay. And then on the columns is the name of other classes, other categories of mental disorders. So we've got psychotic, bipolar, depressive, anxiety, obsessive compulsive, sleep, sexual dysfunctions, delirium, and neurocognitive disorders. And then if that particular substance can induce that, it'll be marked. And a lot of them, it's marked with either with an I, which stands for when intoxicated, and a W, which stands during withdrawal, is the time when this substance can induce it. And if you look, some of the most potent substances for inducing mental disorders are alcohol, the sedative hypnotics, and the stimulants. But they all have certain categories of disorder that they could cause. And then, so what I'll do on each of these then is I'll list the ones that the substances that can cause physiologically affects and creates as part of its profile the depressive symptoms in this case. Then, as I mentioned, corticosteroids and hormones. And we're going to see as we go along that the endocrine system is very much involved with when you take drugs because of issues with the autoimmune and with the endocrine system, that you're going to get, you could induce a mental disorder. The beta blocker medicines, those are used for regulating hypertension. And interesting enough, the statins. Now, there's a wide variety of statin drugs. They're used to manage cholesterol. And they have found that one of the effects of the statins is the physiological creation of the biochemistry needed for depression. And the solution of all of these, of course, is to stop the medication and treat the depression. But if it is indeed caused by a substance, and you'd want to confer with the prescriber if they thought that this was likely, the diagnosis is not like major depressive disorder. The proper diagnosis is the name of the substance-induced depressive disorder. So let's just say pravastatin, which is a statin drug, induced depressive disorder. You put in the actual name of the substance or medication. We also then have to always consider, could the symptoms, the pattern of symptoms and the syndrome of depression be due to a general medical condition? And there are enough, depression has quite a few. And so if talking about that, then we notice stroke and Huntington's disease, Parkinson's disease, and traumatic brain injury. So things that affect the brain and the nervous system. We talked about endocrine. Here it's diabetes, Cushing's disease, and hypothyroidism. Fall allergies. Leaves dying. multiple sclerosis, post-COVID syndrome. We're learning so much about that. Even some people who have had mild cases of COVID develop symptoms of anxiety and or depression. Excuse me. And then Lyme disease. Depression is often a symptom of Lyme disease. If this is the case, then the diagnosis is depressive disorder due to, and you insert the name of the medical condition, such as Parkinson's disease. And I want to say something about COVID, long-term COVID symptoms. In 2022, just this year, the authors listed in the bottom did a review of all the and meta-analysis of all the research that had been published, released related to symptoms after COVID. You were no longer testing positive, and they found 18 papers with research studies that were 1 year follow-up information, and for a total of 8,591 survivors. And so at the 1 year mark, they looked at the symptoms and what percentage of the people had them. So we'll see that the first, fatigue and weakness and arthromyalgia, physical symptoms. All the ones and below are mental disorders, and we have a little under a quarter still have depression, and then 22% have about the same amount have their symptoms of anxiety. Around 20% have some memory loss and concentration difficulties, and then a little over 10% have insomnia. And what's gender related, they're finding that female patients and those that did have the more severe initial illness are more likely to continue to have symptoms after 1 year. So that now becomes something you should always ask about when you have when you're sorting through in that initial exam with a client. Okay, so then we have to, let's say we've checked out the medical condition, including COVID. We've checked out substance and medications, prescribed medications. And so now we know it's not. So now we got to look, what mental disorder specifically would this be? And in the category, in the DSM, for depressive disorders, there are 4 disorders. The disruptive mood dysregulation disorder, which is diagnosed in children and adolescents up to 18. Major depressive disorder, persistent depressive disorder, and premenstrual dysphoric disorder, which is particular to women who have menses. So that what we're so we need to look at that. Those are considerations, but there are other mental disorders categories that also have as part of their symptoms a syndrome of depression, along with other syndromes. So that we have the bipolar disorders, bipolar 1 and bipolar 2. And in fact, bipolar 2, those clients with that rarely, exceedingly rarely, will come for therapy when they're hypomanic. No, because they think that's normal, but they have deep depressions. And so we have they almost always present with depression. We have trauma and stressor-related disorders that have depressive symptoms with them: post-traumatic stress disorder, adjustment disorder, and prolonged grief disorder. So we have to differentiate on these categories. And that means we're going to have to add, once we get clear that we've got a depressive syndrome, we've got to ask a few more questions to help us make the appropriate diagnosis. So one is, has there been a history of periods of heightened mood, energy, irritability, decreased need for sleep? And if the answer is yes, then you want to consider bipolar disorder. And then did the family history include bipolar disorder? And then if yes, then again, you really need to gather more data. Bipolar 1 is heavily genetic in terms of polygenes for psychosis and familial family genes. So anytime you have a client with that family history, it really needs to be considered carefully. Has there been a history of one or more traumatic events? We always, during that, if it doesn't come up during the focused part of the interview, we ask about traumatic events. And so did the negative effects and other symptoms come up after the traumatic event? And then we'd want to look for things like intrusive thoughts, arousal, and avoidance symptoms. And if the answer is yes, then we think about trauma and stressor-related disorders. And then, is there a history of loss? This is new because of the added to the TR. Is there a history of loss of a significant person at least 12 months ago? And if yes, then we should consider, is it prolonged grief disorder? So all of these have their symptoms of depression, but if we need to explore further and collect other information to differentiate. So let's say we didn't, that none of those came out. So now how do we decide which depressive disorder? And we have the primary disorder in this section is major depressive disorder. And see this little crown up here? It should be familiar to you. Of course, maybe not now that people don't send greeting cards as much, but that's Hallmark's symbol, Hallmark greeting cards. And so I stole it from them and put it here because in each category, there may be a hallmark disorder. And in this case, it's in depressive disorders, it's major depressive disorder. And what a hallmark diagnosis is, it's the one against which all the others push to be diagnosed. So that means in order to diagnose another one, I have to be sure, I have to have first determined it's not major depressive disorder. So it would be helpful to memorize then what is the criteria, what are the major criteria's sections for major depressive disorder, so that you'll ask the right questions to determine during the intake, so you'll be able to know which depressive disorder it is. And we have symptoms that are probably very familiar to you. It wasn't changed in the 5TR, and that is that there has to be an episode of depressed mood and or diminished interest or pleasure most of the day, nearly every day for at least 2 weeks. Plus, there have to be 4 other symptoms from this list. Weight gain, weight or loss, insomnia, hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness and guilt, diminished ability to concentrate or indecisive, and recurrent thoughts of death, suicidal ideation or a plan, an attempt. And remember I said there's has to be their criteria, and then there's has to not be there, not criteria. And that one for depressive disorder is there has never been an episode of mania or hypomania. So let's then compare and what is persistent depressive disorder. And this one is part of what determines that is time. So the individual has had depressed mood more days than not for at least 2 years. And it's 1 year in the child. Now, this was changed quite a bit in the 5. It remains the same in the 5TR, but it's, it is seen more, a persistent depressive disorder is more like a reduced major depressive disorder, but it never goes away. Whereas depressive disorder is episodic. You have the episode, then you're better. You have the episode and you're better. So for persistent depressive disorder, we have to have 2 or more symptoms while depressed. Poor appetite, overeating, insomnia, hypersomnia, fatigue or low energy, low self-esteem, problem concentrating and making decisions, and feeling hopelessness. Now, notice that these symptoms are very similar to this list for major depressive disorder. So it's more a matter of what's the difference? Well, if you notice, recurrent thoughts of death, suicidal ideation, or suicide plan or attempt is only in major depressive disorder a symptom. And the feelings of worthlessness and excessive guilt is not part of persistent depressive disorder. And the psychomotor agitation and retardation is part of major depressive disorder, but not persistent. So we can say that the differential then is that one is episodic, major depressive disorder. Persistent depressive disorder is most days for at least 2 years, the person has been this way. And then the intensity of the symptoms and some of the symptoms are different for the two. Let's look at another one. Adjustment disorder with depressed mood. Well, there has to have been an identifiable stressor, whereas in major depressive disorder, there may not be an identifiable stressor that initiated the episode. And it has to have been 3 months or less the time sequence when the symptom, after the stressor, the symptoms developed. Then and remember, we talked about the exclusion criteria. It does not meet the criteria for another mental disorder. And so, of course, if it does, then you have to diagnose the other mental disorder, even though they both have depression as part of the profile. And then we've talked about prolonged grief disorder. And in this case, one, there is the loss of a very close deceased person who died at least 12 months ago. And the distress is focused on feelings of loss and separation from the loved one, rather than the sadness, the lack of pleasure, and so on. Okay, so comorbidity. Major depressive disorder has a very high rate of comorbidity. Over a lifetime, 72% of individuals with a diagnosis of major depressive disorder will have a comorbid disorder at some point. So among adults with major depressive disorder, then they'll have one or even more COVID disorders. And in the study, the comorbidity survey, which I hope they very soon repeat because now it is 17 years old, we have 59% of those that had major depressive disorder had an anxiety disorder as well. 30% had an impulse control disorder. Now, this is a little confusing because in 2005, they were using the DSM-4 for the diagnoses, and there were many more diagnoses in impulse control disorder at the time. And so basically what that says, though, is that you want to look at things that they used to include hoarding and body dysmorphia and all those kind of things as an impulse control disorder. And so that's where the comorbidity would be rather than conduct disorder. And then 24% or a quarter of all the individuals with major depressive disorder had a substance use disorder as well. Now, I know those of you who are paying close attention say, but Peggy, that can't be right. It adds up to more than 100. But remember, some of these individuals have both like depression, a substance use disorder, and an anxiety disorder. You know, so that there's multiple comorbidities in one person. in some of these cases. And this, I thought, was a very important fact in this report, and that when comorbid disorders are present, the major depressive disorder usually emerges after the primary disorder. And so major depressive disorder follows an anxiety disorder in 81% of the anxiety disorder cases. In 81% of the cases where that's the comorbidity. I misspoke. So what does that suggest? Well, if you have a client and you notice that in addition to a pattern of depression, you've picked up a few anxiety symptoms, you better look much more closely, because there's a lot of that combination, and the anxiety emerges first. And then the major depressive disorder, in 59% of the cases, follows a substance use disorder. So, in a sense, when the patient presents with a major depressive disorder, you really need to look at prior history and at what else might be going on, because the depressive disorders tend to be the second disorder that emerges. Oh, good. It's brain teaser time. Okay, so to help move the afternoon along, we're going to have a brain teaser contest, and to see who is the best diagnostician among us. So, and we're going to use cases. So we're going to start with Joe. And the question you will be asked is, Joe has a gambling disorder. What other DSM-5 TR mental disorder is comorbid? So that's the question you're going to be asked. And let's go to the case. Again, I'll read along. I'll read and you follow along. No, I'll read along. You read it out. Okay. Joe is a 59-year-old male, white male attorney, referred for counseling by his lawyer. Joe reports difficulty concentrating, impaired functioning at work, tension, aches and pains in his legs, insomnia, and loss of appetite. For the past 15 years, he has been taking the money his clients gave him to invest for them and used it to gamble. Joe defends this practice, saying he sometimes actually paid clients more money than they would have gotten had the investments been made. I think we call this a pyramid scheme. He had been able to keep this deception secret until recently. He feels much guilt about what he has done. Joe always viewed himself as a skillful and winning gambler. He now admits that as early as 2010, he was regularly overdrawn at the bank and owed money to casinos. For the past 3 years, Joe increased gambling to escape his ever-increasing debts and to replace the client's funds. Unfortunately, his chasing buried him even further in debt. This year, when he finally realized that he was not going to be able to do this, he states he became most anxious and depressed. Before he decided to seek an attorney and turn himself in for embezzling from his clients, he began to think about suicide daily, how he had betrayed everybody, and if he killed himself, at least his wife would have the insurance money. He still has not told his wife about the extent of his gambling losses, nor the legal difficulties. He hoped he could win enough money to replace the client's funds and undo the problems before she would find out. Joe cries frequently during this session and appears overwhelmed by the enormity of what he has done. His thoughts center on self-disgust and anger at himself. He repeatedly says, "I can't believe I could do such a thing. I can't believe I did this." So that's Joe. And now the question is, yeah, we know he has a gambling disorder. He has gambling disorder, but I have 4 conditions here, specific diagnoses that would be on our differential possible list. But only one of these is probable, and that is pretty sure he meets the criteria for that. So I'm going to put up a poll. And what I want you to do is answer your answer of what is the other DSM-5 mental disorder. Okay, I'm going to leave it up another 20 seconds, so get your answer in. I've still got 30% of you to choose. And, it's more fun. You got to take a risk, give an answer. Okay, I'm going to end the poll and share the results. So we've got about a little over half of you think he has major depressive disorder. And followed by just under 30% thinks that he has an adjustment disorder with depressed mood. A few of you are wondering about conduct disorder, and 10 are thinking maybe it's attention deficit hyperactivity disorder. And remember, all of these are possible. But let's look now and see what is the correct diagnosis. Okay, so what we have to do is we have to eliminate ones that don't meet the full criteria. And so I'm going to start with the one that got the ones that got the fewer. And I just removed conduct disorder. Conduct disorder, the criteria is on page 530. Okay, and for conduct disorder, a repetitive and persistent pattern of behavior in which the basic rights of others or major age-appropriate societal norms or rules are violated, as manifested by the presence of at least 3 of the following 15 criteria in the past 12 months, with at least one of these around for more than 6 months. So we have aggression to people and animals. No. Destruction of property. No. Okay, deceitfulness or theft. Let's look into that. 10, has broken into someone else's house, building, or car. 11, often less to obtain goods or favors. Theft is often less to obtain than or to avoid obligations, i.e. cons others. Has stolen items of non-trivial value without, no, so he doesn't meet those. Serious violation of rules. Stays out at night despite parental prohibitions before the age 13. Has run away from home overnight at least twice. Is often truant from school. Okay, and says here, criteria C, if the individual is age 18 years or older, criteria does not meet antisocial personality disorder. And B, you can see it's not matching. Now, I will say this, and you're thinking of how he kind of did unethical things, that there is as you can tell from the criteria, the criteria is not based on white collar kinds of conduct. And so often they don't get an antisocial personality diagnosis when they would qualify for it. But in this case, it seems like it was because he couldn't control his gambling impulse that he got himself into this mess. But he was willing to divert funds. Okay, now the other one that got fewer votes was attention deficit hyperactivity disorder, and that the criteria for that is on page 68. A persistent pattern of inattention or hyperactivity, impulsivity that interferes with functioning or development. And so they have the symptoms of inattention. He probably has more of this hyper, you notice the impulsivity. And so for that, he would need 6 or more symptoms in adults, they only need 5. So fidgets, leaves seat, runs around, unable to play or engage in leisure activities quietly, is often on the go, often talks excessively, often blurts out answers, often has difficulty waiting turn, often interrupts or intrudes on others. We don't really see that. So while there are signs that he has tension, he doesn't have enough criteria symptoms for ADHD. So, okay, now that leaves us between major depressive disorder and adjustment disorder. Now, major depressive disorder is the hallmark in this category of depression. So if he meets that criteria, then that's the diagnosis. Because remember, in adjustment disorder, it can't be better diagnosed by the criteria of another mental disorder. So he either meets major depressive disorder criteria or not. And so let's take a look. Oops, what happened? Oh, I went the wrong way. Sorry, guys. There always has to be some technical difficulty. There. So he has to either have depressed mood, and he does nearly every day and then he has to have 4 other symptoms, and he has insomnia, feelings of guilt, recurrent thoughts of death, and he's sort of agitated. So yes, he's tense, and he has never had an episode of mania or hypomania. I'd be inclined, just with the profile, to carefully check that, but we're going to say it's not in the case, so we're going to say no. So he meets the criteria for major depressive disorder. So if you gave yourself, if you selected that one, put a star, if you printed out the slides, put a big star by that one. Give yourself a star for correctly thinking that through. Now let's go on to anxiety disorder, where the dominant symptom are symptoms of anxiety. Now, this anxiety is a very difficult diagnosis, an anxiety disorder, because anxiety is a common symptom of all of us. It's a warning, it's a human's warning that something is wrong, or that I've got to be alert and pay attention. It's an impending threat. And so anxiety is a state of heightened arousal that is future-oriented. So physiologically, what our body is doing is that arousal is preparing us to manage or cope with a real or imagined negative event, like failing a licensure exam or getting out of the thunderstorm because you'd be hit by lightning, maybe. Okay, so everyone has anxiety. How do we draw the line? When does it become an anxiety? The syndrome of anxiety takes the pattern of an anxiety disorder. So one of the things is the excessiveness of the anxiety. So here, if we look again, what are the key symptoms that we have to know? And it's arousal. Okay, and this is central nervous system arousal and skeletal muscular tension, and that tension in the voluntary muscles, okay, associated with high levels of negative affect, chronic overarousal. So not only is it a state of arousal, the person's in that state a lot, it's chronic, and a sense of uncontrollability. Now, what then would I see, or would the client tell me about in the clinical interview that would help me recognize that this is the syndrome of anxiety? And that would be feeling on level 1, it's feeling nervous, anxious, frightened, worried, on edge, feeling panic or being frightened, in avoiding situations that make you anxious. And then we have level 2, cross-cutting measure. And on that, the symptoms are, I feel fearful, I feel anxious, I felt worried, I found it hard to focus on anything other than my anxiety, I felt nervous, I felt uneasy, I felt tense. So when we see the pattern of these together, then we think anxiety disorder. But the key symptoms that have to be there would be the heightened arousal, perhaps usually chronic, and lots of skeletal muscle tension that is accompanied by negative affect and a sense of uncontrollability. Okay, so let's go on. And, we got to do our differential, and we always start it off with, well, is it due to the physiological effects of a substance? And here's some substances that are known to induce anxiety. Alcohol, caffeine, cannabis, inhalants, PCP, opioids, hypnotics, and stimulants. And again, I've given you the reference to where that table is in the DSM-5 TR that I used to get this, to see what was related to anxiety, what drug. Then asthma medications, such as albuterol, salmeterol, and phenolphthalein. Then blood pressure medicines, such as methodopa, which is one of the brand names is Aldamet. And then hormones, such as oral contraceptives. Okay, and if that's the case, then the diagnosis is the name of the substance induced anxiety disorder. So we could have alcohol-induced anxiety disorder. And there is a code for that. Then we also have to think about a general medical condition. And there are a number of anxiety, because it's a warning system, it's the body's warning system. There are a lot of developing diseases part of their symptoms. They arouse the body, they turn on our arousal system. So mitral valve prolapse syndrome, which is the person has a mitral valve prolapse, but the syndrome is panic attacks, usually when they lay down in the evening, and migraine headaches, cardiac arrhythmias, coronary occlusions, and MIs. So anything when there's something wrong with the heart, there is heightened feelings of anxiety. Body's warning. Lung cancer, chronic obstructive lung disease, and pneumonia. I can't breathe. My body says, "Ooh, threat, threat, threat." And I have anxiety symptoms. And what makes it then become due to a general medical condition is that it's part of the body's response to the medical condition. It wouldn't be there if it wasn't. Then we have the endocrine diabetes, hyperparathyroidism, hyperthyroidism. Hey, here's Lyme disease again. And I don't know where you all are from, but Lyme disease, I was reading, due to climate change, is spread further and more intense in regions of our country. And so we think, we originally thought about it in the Northeast, but now we've got it in the Midwest as well. So post-COVID syndrome, I've already mentioned that. And in case of anxiety, vitamin B deficiencies. Vitamin B is the different B1 through 12. Those are help regulate the nervous system. So it makes sense that if you had a deficiency, then you would be experiencing arousal. And in this case, then it would be anxiety disorder due to, let's see, Lyme disease. In this, okay. Now, we're going to say, okay, we check that out. They don't have either a medical condition or a substance that could have induced it. What are the mental disorder classifications with symptoms of anxiety or fear? Not just having anxiety, but that there is a syndrome. And back in, if you recall, in the DSM-4, obsessive compulsive and related disorders and trauma and stressor disorders were in the category anxiety disorders. But with the 5, they kept in anxiety disorders only those disorders that have the key symptoms of arousal and skeletal voluntary muscle involvement, as well as negative affect and so on. And it separated them out, and it was a very good move. So we've got the anxiety disorders, and the other, separation anxiety disorder, selective mutism, specific phobia, social anxiety disorder. Remember, I said it got rid of social phobia completely. Panic disorder, agoraphobia, and generalized anxiety disorder. But there can be similar symptoms of anxiety, but there'll be other syndromes in obsessive compulsive disorder and body dysmorphic disorder, in reactive attachment disorder, acute stress disorder, post-traumatic stress disorder, and adjustment disorders. And then in the category somatic symptom and related disorders, remember Rita had somatic symptom disorder. Sometimes there's a lot of anxiety with that. She did not have that, but often. And then a new diagnosis to the 5, illness anxiety disorder, where the person doesn't really have the illness, but is very concerned about getting particular illnesses, or that they're sick in general and it has to be checked out. And they're really focused on that. So all those are possible. So how do we sort? Well, within the category of ones that used to be considered anxiety, they share some common patterns, and we can sort by looking at what's the format of the anxiety, the nature of the anxiety, and in what context does it occur. So in terms of forms we can recognize are there discrete panic attacks? Or is it just a high anxiety level all the time? Or has there been a traumatic or stressful event, and after that, the symptoms developed, the anxiety symptoms? Okay, so then if we have that sort, notice that in terms of having discrete panic attacks, that they could be uncued, and that would be panic disorder. Panic disorder requires that the first panic attack, and there's criteria for panic attack, is uncued. That is, it isn't directly related to a certain circumstance or location. Or it could be cued with panic-like symptoms. And that it is when it's a specific phobia, like to heights, and also social anxiety disorder. It develops when the person is in social situations where they have to perform. And then, or is it situationally predisposed? And as that is, it doesn't always happen when the person's in that situation, but if it's going to happen, it'll be in that situation. So we have panic disorder, separation anxiety, and PTSD. Now, maybe you're thinking, well, you just put panic disorder up under uncued. Well, here's what happens. The person has a panic attack. Like I had a client who was a priest, a young priest, and his first panic attack was while saying Mass. He went back to his home church and he was saying Mass, and he had a panic attack. His second panic attack, totally unexpected. His second panic attack, totally unexpected, happened in a park. So now he's starting to think, and this is what happens with panic attacks. The person starts saying, oh, what's causing this? Oh, well, maybe it's because I had to make go over a big bridge. Okay, maybe it had nothing to do with the bridge, but the mind wants to find meaning. We all do. So often then the panic attacks that follow over time become situationally predisposed. The example I was sharing with you about my client, because it's probably the most threatening, then subsequent panic attacks were always while saying Mass. And he was really frightened and worried that he was going to violate the sacraments, that performing them correctly. Okay. And of course, separation anxiety, the situation is being separated from a loved one, a close loved one. And PTSD, it's triggers and reminders of the trauma. Now, so I'm going to skip high anxiety level just for a minute, and then we'll take care of traumatic. And so this is where the high anxiety or the anxiety symptoms came after the trauma. And so there are 3 types of traumatic events that could do that. Was there severe neglect prior to the age of 3? And that, if so, then think about, and if it fits, look at the other criteria: reactive attachment disorder. Does it follow a traumatic event that meets the criteria for trauma? It could be PTSD, or if it's less than 30 days, acute stress disorder. And then, or is it a stressor occurred, and then within 3 months, the anxiety developed? Well, then we think about adjustment disorder. So here in the middle, this is folks that have high anxiety level all the time. So then we've got to look at what other syndromes or symptom clusters are present. And if there are also repeating thoughts or repetitive behaviors, then it probably is obsessive compulsive disorder you need to consider, and body dysmorphic disorder, where you have repetitive thoughts about something's abnormal, about your looks, your body, your so on. Generalized is truly what it means. It's just that there's a lot of high anxiety level, and it's not necessarily attached to one specific thing. So we talked about substance-induced and due to medical condition. Whenever you see what seems like almost free-floating generalized anxiety, you immediately say to yourself, I've got to differentiate. Is it substance-related? Is it due to a medical condition? If not, then what we have is generalized anxiety disorder, and I'll talk more about that in just a second. And then is this high anxiety level that's here all the time, is it focused on physical illness, like in Rita? And in that case, we got to think about somatic symptom disorder or illness anxiety disorder. Okay, so let's say we've said, nope, it's generalized anxiety, which that category in the middle. So and it turns out that generalized anxiety disorder is the hallmark, because all the others are more distinctive. They have some other characteristic. So this is kind of, there was a period of time when we thought that generalized anxiety disorder was more like an underlying condition. For all anxiety disorders. But what we do now is it's recognized by a particular pattern. And so the person has excessive anxiety and worry more days than not for at least 6 months. And it has to be about a number of events or activities. So I'm not just worried about my coursework. I'm worried about my children seem to be sick, or I worry about my pet has cancer, or I'm worried about my husband and his job, or I'm worried about climate change, or maybe all of them together, maybe. So I have to be worried about a number of events or activities, because when I'm worried about one focused area, then it's a different anxiety disorder. And then the other feature of generalized anxiety disorder is the person feels like they can't control the anxiety. They know they shouldn't be worried about this, but they can't stop. And what are the symptoms beyond what we've talked about in terms of thinking? Children only need one, but adults need three. Being restless or on edge, being easily fatigued, difficulty concentrating, irritability, muscle tension, and sleep disturbance. Now, I bet you're seeing the overlap with depression, major depressive disorder, and persistent. Yeah, I am too. And in fact, that's why it is so difficult to differentiate anxiety from depression until you focus on it. Anxiety has the negative affect and some of those negative things, but it features, there has to be arousal of the central nervous system and voluntary tension in the skeletal muscular system. And likewise for depression, it has the anhedonia, the apathy, and you never call people with anxiety disorder apathetic. But if you look at those symptoms that they share, you aren't going to be able to tease it out. So I got off track just a teeny bit there, but let's look at other things we should think about. So social anxiety disorder also is persistent, excessive anxiety, but it's about social situations where the individual feels like they have to perform or while they're there, they'll be evaluated by others. And it's the social situations that invoke the fear and anxiety. And I've already mentioned in somatic symptom disorder or illness anxiety disorder, the excessive anxiety is focused exclusively on health, being ill, or the seriousness of body symptoms for at least 6 months. Give me a fit. Okay, we're almost ready for a break. All right, so let's do the brain teaser. Man. Okay, we've got a brain teaser. Let's do that, and then we'll go on a break. So this is a diagnosis case, and it's Hunter. And we're going to want to know what is Hunter's primary DSM-5-TR mental disorder. And on our possible differential diagnosis list is separation anxiety disorder, obsessive compulsive disorder, generalized anxiety disorder, and social anxiety disorder. And so we're going to look for the primary. And here's the case. Hunter, a 12-year-old boy, attends one of the city magnet middle schools. Hunter has a close family consisting of his parents and 2 older brothers aged 15 and 19. He says he has always been nervous and teased by his brothers for being a scaredy cat. His mother reports that Hunter was a very shy, reserved little boy as a preschooler, but he integrated well in first grade and began making friends and succeeding academically. This year, he started middle school and he began to complain of severe abdominal pain, which is worse in the morning and never present at night. Over the past 6 months, Hunter has missed 20 days of school and avoided school excursions, fearing that the bus will crash when he's on the excursion. He has difficulty falling asleep and is unable to sleep at all before a test. He frequently checks in with his mother when doing school assignments and chores at home. Hunter is worried that he and/or members of his family might die. When his parents remodeled the house 18 months ago to create a first-floor master bedroom and give each boy his own room, Hunter could not tolerate having his parents sleep on a different floor of the house than himself. Fearing intruders, he began insisting on securing the house in the evenings, which his mother reports is to an unnecessary extent. Hunter's insecurity and his persistent need to check in and school absenteeism are frustrating and upsetting to his parents, both successful dentists. Neither Hunter or his parents could recall any prior experience of traumatic events. Hunter denies the use of substances other than Pepcid Complete for his stomach. Okay, so that's Hunter. And now we have to figure out what is his primary. And here is the poll. And again, if you would pick out what you think Hunter has as the primary. About 20 more seconds. So I need a few more of you to commit. Okay, I'm going to end the poll and show you the results. Okay, so we have a spread again where we have two that get quite a bit more, and then we have everyone has selected, at least one person has selected each of these. And it's not surprising because these are on our possible list. They wouldn't be on here if they weren't possible. Okay, so 50, a little over half of you think it's generalized anxiety disorder, and a third of you think it's separation anxiety disorder as the primary. And then we have 9 each thinking obsessive compulsive disorder and or other specified anxiety disorder. So let's figure this out. And let's start with the ones that received the lowest. And well, I'm going to start with social anxiety disorder. And social anxiety disorder is on page 229 of the manual. Oh, I need my reading glasses. Okay. I'll have to get them during the break. The social anxiety disorder, marked fear or anxiety about one or more social situations in which the individual is exposed to possible scrutiny by others. And I guess that what you were thinking about was school. It says in the anxiety in children must occur in a peer setting and not just interaction with adults. So we've got school. B, the individual fears that he or she will act in a way or show anxiety symptoms that will be negatively evaluated. The social situation almost always provokes the fear and anxiety, which can be expressed by crying, tantrums, freezing, clinging, shrinking, and failure to speak. I don't think we've got those. And avoiding social situations. While he has maybe a little bit of flavor of that, notice how this doesn't really fit. He isn't fit. He's got a lot more going on than that. So I think we can remove that from our list. Oops, what have we got here? Okay. All right. We'll remove that from our list. And then let's look at the other one, obsessive compulsive disorder. And on page 237 are the criteria for that. And the presence of obsessions, compulsions, or both. Obsessions, you have to have both 1 and 2. Recurrent and persistent thoughts, urges, or images that are experienced at some time as intrusive and unwanted. And 2, the individual attempts to ignore or suppress such thoughts. Okay, that doesn't fit. How about compulsions? There have to be both 1 and 2. Repetitive behaviors that the individual feels driven to perform in response to an obsession or to follow rules excessively. Now, I think I think you were probably thinking about checking the locks. And the behaviors or mental acts are aimed at preventing or reducing anxiety or stopping some dreadful event. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to do. It's a little realistic. The obsessions or compulsions are time-consuming, take more than 1 hour a day, not really, and cause distress. In the disturbance D or exclusion, it's not better explained by the symptoms of another mental disorder, such as excessive worries, as in generalized anxiety disorder, preoccupation with appearance, difficulty discarding objects, hair pulling, etc. It's a long list. I'm going to say that he doesn't, I think there is something that meets that better than obsessive compulsive disorder. So we eliminate that. That leaves us with generalized anxiety disorder and separation anxiety disorder. And the funny thing is, every time I do this workshop, these two are like the two that always are harder to differentiate. And will not keep you in suspense because I need to say what the answer is and then go to the other to show what the issue is. And so let's look at separation anxiety disorder, which is on page 217. See the sneaky way I'm putting in, you learning some of the criteria. Okay. Separation anxiety disorder. Developmentally inappropriate and excessive fear or anxiety concerning separation from those to whom the individual is attached, as evidenced by at least 3 of the following. Recurrent excessive distress when anticipating or experiencing separation from home or major attachment figures. Persistent and excessive worry about losing the major attachment figures or about possible harm to them. Yes, the first 2 are yes. Persistent and excessive worry about experiencing an untoward event like getting lost, being kidnapped, having an accident, becoming ill that causes separation from a major attachment figure. Yes. Persistent reluctance or refusal to go out away from home to school, to work, or elsewhere because of fear of separation. He's reluctant to go to school because he has a stomach ache, but he is reluctant. Persistent reluctance or refusal to sleep away from home or go to sleep without being near a major attachment figure. Yes. Repeated nightmares. No, we haven't heard about that. Repeated complaints of physical symptoms, headaches, stomach aches, nausea, vomiting, when separation from attachment figures occurs or is anticipated. Well, he has to have at least 3, and he has 7. The fear, anxiety, or avoidance has been lasting more than 4 weeks in children, or more than 6 months in adults. One of the things that happen, remember, is now with the DSM-5 and the DSM-5-TR, diagnoses are lifespan. This used to be in the child section, but now it's recognized that adults can develop this. And then C, the disturbance causes clinically significant distress or impairment. He's not going to school. And it's not better explained by another mental disorder, such as refusing to leave home, senses excessive resistance to change, like an autism, delusions or hallucinations, about separation and psychotic disorders, or about harm befalling significant others in generalized anxiety disorder. Okay, so he fits the bill. So let's look at generalized anxiety disorder, which was the most frequently chosen option. And here's where I always have the debate. A, generalized anxiety disorder on page 250. Excessive anxiety and worry occurring more days than not for at least 6 months about a number of events or activities. So we could say what? School performance, because he's nervous before a test. And people getting into the house. Maybe. The individual finds it difficult to control the worry. Well, actually, he does things to control he checks the locks, he gets stomach aches and feels that rather than anxiety. The anxiety and worry are associated with 3 or more of the following 6 symptoms, but children only require 1. Restlessness or being keyed up or on edge. Haven't heard about that. Being easily fatigued. Haven't heard about that. Difficulty concentrating. Haven't heard about that. Irritability, muscle tension, sleep disturbance. He doesn't meet those. And since he more than meets the criteria for separation anxiety, I would say his primary is separation anxiety. So if you got that right, give yourself a big star. And now we're going to take a break. I'll see you back and my clock, it's 3:45. So it's 45 minutes past the hour. I'll see you back on the hour. For me, that would be 4 p.m. Central Time. And then we've got 1 hour to go. Well, time to start again, huh? Okay. What I'd like to do is answer a few questions, and then we're going to speed up because we've got just an hour left. A couple of you I've answered in writing for everyone to see, but Dawn asks, how do you screen for post-COVID issues versus current symptoms? How do we look at how COVID isn't? Well, we're not saying that these aren't current symptoms. When you have, what they're finding is that with COVID, after the person is no longer testing positive, they keep having symptoms. Number 1 is the fatigue. And this was a study of people who were having those current symptoms of anxiety or depression 1 year after. And what you would think about is, have these continued ever since they've had COVID? That would help you know if that it was related to that and it wasn't, say, another recurrence of major depressive disorder. Stephanie asks, is prolonged grief disorder specific to a death of a loved one, or can it be a divorce, separation, loss? That's a great question, but it has to be the death of a loved one. It can't be a pet. It can't be a loss of a job, and so on. It's specific to another person. And then Jasmine asks, would you mind repeating what you had said earlier about the hallmark diagnosis in a category as related to other diagnoses in that category? Yeah, I'll do that on when we do the next syndrome, psychosis. I'll highlight it a little bit more. Okay. Well, I enjoy getting your questions and answering them. And so now let's continue. So I just want to point out that the anxiety disorders also have a high comorbidity rate. And the interesting thing, which I don't seem to have here in a statement, and I should have, is that they're most frequently comorbid with each other. Now, that could easily be an artifact of the DSM categorical system, because the boundaries between disorders, remember, are drawn arbitrarily in saying this is this category and this is that category, where in reality, most of disorders are on a continuum of different symptoms. But that currently is the most frequent comorbid with anxiety disorders. I would suggest, because each anxiety disorder has its own pattern of other disorders that are comorbid with it, you consult when you have a diagnosis of an specific anxiety, to consult the comorbidity section. And we haven't talked about that, so I still have my DSM open to the generalized anxiety disorder. And so if you will turn to page 254, which is where there's not a lot of text on generalized anxiety disorder, but there is a paragraph on comorbidity at the end, and it says, individuals whose presentation meets criteria for generalized anxiety disorder are likely to have met or currently meet criteria for other anxiety and unipolar depressive disorders. The negative affectivity or the neuroticism or emotional lability that underpins this pattern of comorbidity is associated with temporal antecedents and genetic and environmental risk factors, etc. So be sure to read in the text the first time you have that diagnosis, or maybe every time, about comorbidity. Most frequently encountered, other than other anxiety disorders, are depressive disorders, bipolar disorders, and substance use disorders. I think we're starting to see a pattern here of comorbidity. Patterns of, excuse me. Okay, let's go on to psychosis. We think of psychosis with schizophrenia, but it's actually in a lot of other disorders. So what are the key symptoms? It's abnormalities in one or more domains, cognitive domains of delusions, hallucinations, disorganized thinking, abnormal motor behavior, and negative symptoms. And so the client will describe the following: that there is not, there's the symptoms on the cost-cutting measure. And then because there's not a level 2 for psychosis, I pulled from other resources, seeing, tasting, or believing things that others don't, persistent, unusual thoughts or beliefs that they can't set aside, strong and inappropriate emotions or no emotions at all, withdrawal from family and friends, a sudden decline in self-care, and trouble thinking clearly or concentrating. We have a differential diagnosis, and there are a number of medications and illicit drugs of use that can induce a psychotic disorder or a state of psychosis. And alcohol, cannabis, inhalants, hallucinogens, opioids, sedatives, hypnotics, anxiolytics, and stimulants. Pretty well got all of them. Anticholinergic agents, anticonvulsants, antihistamines and decongestants if someone's sensitive to their impact, cardiovascular, antihypertensive medications, steroids, gastrointestinal medications, and muscle relaxants. That happened to my brother-in-law. He had spinal disc surgery. They, gave him muscle relaxants and pain medications to take home because he wasn't kept overnight. And my sister calls me around midnight, panic, because John's talking to someone that's not there. He's having, and I asked, I said, well, did he get a muscle relaxant? She said, yes. I said, you better call the doctor and check on it. And sure enough, when they quit it, he was no longer talking and having hallucinations. Then we have general medical condition, and these tend to be related somewhat to the brain, but again, we see endocrine and metabolic disorders, autoimmune disorders, temporal lobe epilepsy, and neoplasms in the brain. And probably the one we most frequently encounter are either the autoimmune, like the individual has severe lupus, or the neoplasms in the brain. Same format. They are not given, they are given a different medication-induced psychotic disorder or psychotic disorder due to a medical condition as the diagnosis. Now, it turns out that psychosis is present in all the disorders in the schizophrenia spectrum, but is also present in some other disorders. Now, you ask about the hallmark, and I'll try to explain it in a somewhat different way. When you're making a diagnosis, the way the DSM is patterned, there often is a diagnosis that's kind of like the standard bearer. It is what all the others, that whenever you get a symptom of psychosis, then you make the diagnosis by comparing your possible disorders to the hallmark, that is kind of the prototype diagnosis. Turns out in schizophrenia, it's the whole spectrum. So you're either somewhere on the schizophrenia spectrum, or if you don't meet those criteria, then you have to look other places. And we're going to talk about some more of those. So in the schizophrenia spectrum, if we take a look, we notice that there is that on the continuum at the lower end, there's fewer symptoms of psychosis and briefer time. So a delusional disorder, it's all there is the delusions, and it's for greater than a month, but oh, you know what? I've turned these around on this slide. Delusional disorder is less than a month, and only delusional, no other psychotic symptoms. No, that's right. I got it right. You ever have those fades in the afternoon? Okay, so then brief psychotic disorder, you have any one of the psychosis symptoms, but you have more than just one, for less than a month. That's what you tend to see in like borderline personality disorder, when they're under a lot of stress and they decompensate. They may have a brief psychotic disorder. Schizophreniform, the psychosis symptoms from 1 to 6 months. Schizophrenia, at least 2 psychotic symptoms persisting for over 6 months. So you can see that in your initial encounter, in the initial psychotic episode, you might be changing diagnoses from brief psychotic disorder to schizophreniform to schizophrenia. So generally, there's a progression but we're talking about individuals in brief psychotic disorder and schizophreniform. They have that diagnosis. It implies a time-limited time that they have the psychosis, whereas in schizophrenia, it's a persistent, at least 6 months or more. And then I alluded a little bit to schizoaffective, and in schizoaffective, every DSM, it's been a little different. And the 5 and the 5TR, the individual meets the criteria for schizophrenia, criteria A. And that's kind of, if you can imagine, it's kind of like the baseline. Criteria A, it's been there for at least 6 months. And it's kind of there. And then the person also, at some times in the illness, also meets the criteria for major depressive episode or for a manic episode. And it says for most of the illness. But the sense is there's one, the baseline is schizophrenia, and then there are manic or depressive episodes at the same time. It's a very severe illness, high suicide rate, other problems, and it is difficult to make, but it is somewhat treatable at this point. Okay, so let's say you said, no, the clients, it doesn't fit any of those. So recognize that you can have psychotic symptoms. You can be delusional, is usually what it is, with bipolar 1 and bipolar 2, and with major depressive disorder. It's a specifier when that is the case. But you would diagnose that only if the individual didn't meet the criteria for one of these schizophrenia spectrum disorders. And in obsessive compulsive disorder and body dysmorphic disorder, where there is no insight, that's and that means they have no awareness that what they're doing has no basis in reality. And, because people with OCD or body they kind of know it's not, but then they go back to it. But if they can, with no insight, then it becomes delusional and would look a lot like a psychosis. All right, now for some more fun. It's now going to get harder because we've covered the differential process. We've looked at frequently encountered syndromes, and they all have a primary category in the DSM and, a chapter. But the next section, I'm going to talk about what are particularly challenging behaviors and affective symptoms that go together that don't necessarily have a chapter, but they are important and can be serious and sometimes life-threatening. So it's an important syndrome or syndromes to recognize. And we're going to start with impulsivity and impulse control. When that is one of the prominent symptom clusters that the client has. And so we tend to talk about a person's impulsive or a person has weak impulse control. And it's so let's explore that a little bit more. So impulsivity is the tendency to act on a whim with behavior characterized by little or no forethought, reflection, or consideration of the consequences. And there are several different kind of concepts or theories about impulsivity. I am I was trained initially in counseling. It was Rogerian, totally client-centered. Then some Gestalt, and then I discovered in my doctoral program cognitive behavior therapy, and that's where I've settled in. So I like this particular thought about impulsivity, that is actually a cluster of cognitive and behavioral actions, cognitive symptoms, and distinguished by three dimensions. One is motor. The person takes action without thinking or taking the appropriate amount of deliberation before they act. It's cognitive. It's a tendency to make quick cognitive decisions. And it's non-planning. So it's a decrease in an orientation towards the future and choosing short-term gains over long-term. It's the folks that, for example, are most vulnerable to scams because, like the old saying, if it seems it seems like something it's hard to believe, then it probably isn't true. About the prince and the other country leaving you money, or now all the things where they tell you you've won and so on. So that's one. Another thought is that impulsivity is a spontaneous response to an impulse. So you think you ought to do this, and there's no consideration of the consequences. It's sort of like cue, action. Now, it is really important, and why it makes it hard to diagnose or recognize this pattern sometimes, is that it can be functional or dysfunctional. What makes it dysfunctional is that it becomes a way it's a way of constant acting. So if the actions are poorly conceived, they're prematurely expressed, like you blurt out something, they're unduly risky, or inappropriate to the situation, that's dysfunctional. And how impulsivity becomes dysfunctional is that over time, these actions result in undesirable consequences, which imperil actually the person's long-term goals and strategies for success. And I have a friend who loves to find a bargain, and she inherited money. She immediately spent it. She spent it on an RV that she didn't know had all these problems. She spent it on a hot tub that was good only for a couple seasons, and that kind of thing. So it's over time, if the person has a long-term goal, because they've already been impulsive in whatever they've done, it has gotten in the way. I do want to say, I need to go back there for one sec, is that functional impulsivity in a situation like someone needs rescuing, running into danger to save someone, those folks are heroes. And often they say, I just did it. I didn't even think. But they're not that way all the time. And so we're talking about an inflexibility of behavior, that they're always impulsive. Okay, well, next we got to think about what are the signs and symptoms of impulsivity. Well, in children, we often get reports about it from not just the client, but from the parents and the teachers. Trouble taking turns in games, aggressive towards other children, grabbing things from people, pushing in line, overreacts to frustration, to disappointment, mistakes, criticism, frequent interpersonal conflicts, or engages in high risk, like unprotected sex, taking dares to take taking drugs, shoplifting, crimes of opportunity. In adults, there's sort of like a breaking point in impulsivity. One level of impulsivity is overindulging in if something's pleasurable. Escalating problems. So, but you act impulsively, and instead of fixing things, you make them worse. Oversharing. That is, you tell someone you barely know, all kinds of personal things about yourself that you probably shouldn't have. Frequent outbursts. In a sense here, what we're doing is we're impulsively responding with our emotions. And then lots of starting over. I had another friend who she would join groups, and she said, "Oh, I joined a writing group. I want to write. I want to write short stories." Then I quit that. The folks there, they weren't really serious about writing or things. But now I'm learning how to make apps, and so it's lots of starting over relationships, etc. Kind of, you can see there's turmoil here. The more serious, really troubling is if there's destruction of property in moments of anger. If there's physical violence at the spur of the moment, the person just gets into a bar fight, for example. Engaging in higher risk sex, self-harm, self-injury, in heat of anger, sadness, or disappointment. These are very destructive forms of impulsivity. And what you're so that's what you hear about in your intake. During the intake, you notice, or as in the first couple sessions, the individual doesn't seem to understand how his or her words affect other people. They don't consider the consequences of their action. They express frequent regret with or without self-criticism over snap decisions they made that didn't work out, and or about angry outbursts that they wish they could take back. There actually are, when we think about differential diagnosis, we got to think, as usual, about substance and medication and medical condition. And here, the list is narrower, but pretty important. The number one, and I've marked it, is that you got to think about substance use and intoxication that induced the behavior. Freud said that the ego was could be liquefied easily, and it is. So the superego. So here we have alcohol, cocaine, and stimulants are the ones that are often involved in impulsivity when intoxicated. The atypical antipsychotics, of which you see prescribed a lot, Abilify and Latuda particularly. This is the person's gets up and buys things online, all kinds of things. You hear stories, and so it is a side effect. It also, and I don't have it listed here. Oh yeah, I do have it listed here. It's kind of a combination, and that is Parkinson's disease. The drugs itself can contribute to and the impulsivity is due to the disease process, but also the medications seem to impact it to some extent too. Then other neurocognitive disorders that are associated with impulse behavior, traumatic brain injury, and after a stroke. And once you find after a stroke, there really is often issues with impulse control and affective regulation. Again, it's neurocognitive. It's due to those particular medical conditions. Now, so what disorders feature impulsivity as one of the syndromes that symptoms the client has? Well, first we have to do a differential, we have to think about what is the pattern of impulsivity. And there are two sort of patterns. One is impaired self-regulation. That is the person regulating their behavior and their emotions. And it results in the violation of social norms and the rights of others. So if there's a persistent pattern of impulsivity of more than 12 months, and it's a pattern, and it results in violation of social norms and rights, think about conduct disorder and antisocial personality disorder. Now, the other pattern is that it's just specific impulses that the person acts on quickly. And when they do that, it results to injury to themselves, others, or to objects. So what in that, rather than a persistent pattern, the client has episodes of failure to resist aggressive impulses. Think about intermittent explosive disorder, impulse to start fires, pyromania, impulse to steal unneeded objects, kleptomania. Now, within that, also other disorders that have a generalized pattern or a persistent pattern of impulsivity. Is it associated with symptoms of distractibility and hyperactivity with onset before age 12? Attention deficit hyperactivity disorder. Remember, some of you were wondering about that with Joe, because he did have impulsivity. Occurring with symptoms of elevated, expansive, or irritable mood and increased energy. Think about bipolar 1 and 2. And in kids, one of the differentials that I worry about is in some regions of the country, there's a big emphasis on kids with bipolar, and then, or there's emphasis on attention deficit hyperactivity disorder. And you really need to try to make a differential, because obviously the treatment and the prognosis are very different. And then, is there a pattern of marked impulsivity, instability in interpersonal relationships, in one's self-image, and in their affect? Think borderline personality disorder as a possibility. And there's some others, in addition to the main ones I pointed out, where it's episodes of inability to control specific impulses. Preoccupied with gambling disorder. Failure to resist the impulse to pull out one's hair. Trichotillomania, which is under obsessive compulsive and related disorders. Failure to resist the impulse to pick one's skin. That's excoriation disorder, also in the obsessive compulsive related disorders. There is some comorbidity among these disorders that have a prominent feature of impulsivity, and so we have substance use disorders. Often folks that want to behave quickly and get short-term gains, they want to feel good quickly. Bipolar 1 and bipolar 2, 60% of them have a comorbid substance use disorder. And attention deficit, hyperactivity, and conduct disorder also have a comorbidity with substance use disorders. ADHD and conduct disorder, 25% of the clients have both conditions. It's comorbid. Now I'm going to skip the case, Haley. You've got a copy of it. And so I encourage you to do it on your own, but I want to make sure I cover the last category I want to cover, and that is clients with experiences of trauma and psychosocial stress. We talked briefly about them in regards to anxiety. But I want to say a little bit more, because as we get more of them, we need to look at how do I differentiate. So again, we do it, but we have a pattern. It's at what type of event. And if it's a traumatic event, that is where the person thought they were in physical danger and were going to die, or could easily die, the post-traumatic stress disorder or acute stress disorder. I've mentioned this before. Extremes of social neglect before the age of 5. This could be just neglect. It could be death of a parent, and so there's no parenting figure or to bond with, because the kids move from relative to relative or so on, as well as physical neglect. But so this is social neglect. And so we have reactive attachment disorder and disinhibited social engagement disorder. And then there's the big category of psychosocial stressors. So it's in response to a stress. It's an over response to a stressor, and that's adjustment disorder and prolonged grief disorder. But and so if we look at these, I want to point out a few others that symptoms develop after a stressor. And we've talked about adjustment disorder and prolonged grief, but there is dissociative amnesia. That is where the person's sense of identity gets separated. Sort of, dissociation is a breakdown between one's identity and one's feelings and sense of space in the world. And so dissociative amnesia, there's an inability to recall personal information about yourself, identity, after a stressor. In functional neurological symptom disorder, remember that was conversion disorder, that's now got this name. There's an altered voluntary motor or sensory function that becomes a stressor. They're under stress. An example, one of my classmates in high school, all of us that went off to college, he was among them, and he was in a tough engineering major, And he wasn't doing well. And come November, he developed paralysis in his right arm, and he was right-handed. And this was before we have all the talking programs and all that. And it was a functional neurological symptom disorder. Brief psychotic disorder in response to a marked stressor. And so there the diagnosis would be brief psychotic disorder, that when you get psychotic symptoms after a stressor. And the person has had none of the above events, and they have symptoms that are characteristic of a trauma-related disorder, but do not meet the full criteria for any disorder in that category. It would be an other specified trauma and stressor-related disorder. Now, I kind of whizzed through that. I do want you to really be aware of this. The trauma and stressor-related disorders have high rates of comorbid disorders, estimated to be greater than 80%. So in adults with PTSD, you need to consider comorbid depressive, anxiety, and substance use disorders. And they found that in U.S. military combat veterans, there was a 48% co-occurrence with mild traumatic brain injury. That was the comorbid condition. Children with PTSD, the most frequent comorbid disorder is oppositional defiant disorder and separation anxiety. And an individual with reactive attachment disorder, remember that develops after the stressor of severe social neglect. Most frequently, there'll be cognitive delays, language delays, severe malnutrition, and depressive disorders. Okay, it looks like I might have time. Let's go back to the case, and we'll just do it real quickly. Our choices are, does Haley have a conduct disorder, disruptive mood dysregulation disorder, attention deficit hyperactivity, or oppositional defiant? And we'll do this quickly, and then I'm going to have at least 5 minutes to look at more questions if you want to put those in. Haley, when asked to tell the therapist about the issues and problems that led to her mother bringing her to the clinic, Haley said, "Mom can't handle me. She looks older than her age of 14. She's neatly groomed with multiple piercings in each ear and makeup." After her first statement, Haley is nearly silent, sitting with downcast eyes and answering questions with monosyllables. Or, "I don't know." With shakes of her head, she denies feeling depressed, using drugs or alcohol, and having suicidal ideas. When asked about hearing or seeing things that aren't there, she replies, "Well, that's dumb." Her mother's request for an appointment followed a phone call from the assistant principal requesting a conference. Haley has been throwing away or ignoring homework assignments she could have easily completed and is now failing several subjects. Her mother describes her as being difficult from the time she was a baby. She never seemed to sleep, and she was and still is the world's pickiest eater. Haley will argue about anything. She'll argue until she's grounded, and then she loses her temper, and then I take away her phone. When asked about violence, her mother said that Haley sometimes gets so angry she slams doors, but she has never been destructive or violent toward people. There has been no history of stealing, and she almost always tells the truth. The mother noted, Haley is never willing to take responsibility. According to her, bad things happen because the teacher has pets or that I'm being unfair to her. Now, our choices: conduct disorder, disruptive mood dysregulation disorder, attention deficit hyperactivity disorder, and oppositional defiant disorder. And I'm going to throw open the poll. And if you're not asleep, please indicate what you think it is. Okay, I've got about 50 more I got to put in. And I'm going to close it in 15 seconds. Okay. Well, here's what you all thought. And just under 50% think it's oppositional defiant disorder, and 39% think disruptive mood dysregulation. I'm going to do this one a little bit different than we have. I'm going to go back to our kind of shot of things. And so we have impaired self-regulation that results in violation of social norms. And remember, we looked at conduct disorder and when we had Joe, actually, and it really requires theft and dishonesty and hurting others and so on. So that doesn't fit. So let's go. Okay, so we have to have both distractibility and hyperactivity before the age of 12. That's still possible then. And I don't see, I thought oppositional. Nope, not seeing it. Okay, so let's go back. So much for that experiment, right? Okay. And if you look at disruptive mood dysregulation disorder, which is a good thought, because there is an overlap between it and oppositional defiant disorder. She meets criteria A and B with kind of a stretch, but not C and D. And D, of course, is better explained by another mental disorder. And remember, the theme is impulsivity. And disruptive mood dysregulation disorder does not have that. It has a lot more of the irritable and angry. ADHD, she meets a few of the inattentive symptoms, but not 6. For criteria A, conduct disorder, her behavior is not severe enough. And if you look at OD, oppositional defiant disorder, she meets criteria for that and at the moderate level. So if you were among the 50% that picked oppositional defiant disorder as the most probable, pat yourself. And I hope some of you I hope we had a person that got all of them, all 3 stars. Okay, so now let me now go to the end. It will let me go to the end. And just mention that my cats appeared in many of the pictures. And I want to leave this slide. I'm going to answer questions, but I want to leave this here. I will answer questions that I don't get to cover, or if something occurs to you after, as long as I can answer them in like a paragraph. And I'll get back to you. I promise I'll get back to you within a few days. So my email address is on the first and the last slide. I want to offer that to you. Now, let me see. I've got questions here to answer. Oh, it's just a nice Q&A. Thank you very much. I appreciate it. Any other questions? I've got 5 minutes. Okay, I've got a question for you guys then. And here it is. Let's see where I got, oh, stop sharing. Now, what is your level of confidence now in completing a differential diagnosis? Ignore the, the routine and so on. I just want to know, based on today, high, medium, low, or you're not sure. Okay, I need about 20 more responses, and I'm going to end the poll. Oh, and I suddenly have questions. Okay, so here's the results. It makes me feel good. I should have gotten you at the beginning to be sure. Okay. Maggie asks, can you bill insurance for suicide and non-suicidal self-injury diagnoses? Does insurance pay out on these, or do these diagnoses just complicate insurance billing because they will kick it back? I think I got asked this before and I wrote it out, but the truth of the matter is reimbursement in our country is a mess. And the idea that you have to have a certain diagnosis to be paid for treating a client who needs help is a bit crazy. And to make it worse, we have lots of third-party payers. In every state, it's different. So in general, I would say, if you have a primary F code, you put that first. Remember, these are Z codes now. In the future, they may become something different, but I doubt it. So if you're in an emergency room, I would guess it would be a good code. And it obviously complicates treatment, so you should get more authorized for more sessions. So I can't definitively answer that. She says, Anonymous says, I have a 14-year-old client, or did I miss it? Oh, I pushed this down to, who hears voices telling her to kill her mother. The mom is diagnosed bipolar. Well, she needs a good evaluation, because both of those are very serious possibilities. If you're thinking psychosis, is she on the schizophrenia spectrum? Her age, 14, is a common age of onset of psychotic disorders, but she has a family history of bipolar, which people with bipolar don't always hear voices. That's a pretty extreme version. But I would want to get, she's going to need medication. And so I would involve, if you're in a clinic, I would involve the psychiatrist. I really would want her to be carefully assessed, because there's quite a few possibilities here, and all of them are serious. Let's see. Oh, here's one about Haley. What would you diagnose her if she had been traumatized in the past? This is a good question, and I'm going to end with this. And the others, I'll be glad to get back to you. You got to realize that almost trauma with children is the witch's brew of mental disorders. And you don't automatically have a traumatic, it depends on the trauma, of course, and what the child's reaction is. But all the trauma can be the beginnings of things about the child. It doesn't necessarily have to be PTSD. And so I would look. All right. I'm signing off. End of the show. Thank you very much.